So Deepak, would you like to go ahead, or should I introduce our chairpersons to give some wise notes for just to start with this webinar?
You can go ahead, sir.
Okay. So good evening, friends. And this evening we are going to have a good live webinar on glaucoma. All you want to know about the glaucoma. So this is basically for some specialists and also some for beginners and for students also. Those who are attending this webinar may definitely will be benefited. We are going to cover almost every aspect of the glaucoma: how to diagnose, how to handle the instruments, how to treat the patient, what is the medical line of treatment, what is the neurological disorders which mimic with the glaucometal fields and other so many things altogether. So if someone is attending this webinar, they will be quite beneficial. Just I'm getting a noise out of it. Can you stop this noise, please, from the inside?
Sir, I would request everybody to mute their mics, please, except the speakers.
Okay.
I request everybody to mute their mics except the speakers, please.
So anyway, so we have a proud proficient Professor Dr. Ashraf. Humayun Ashraf is there. We want some words from him. Kindly give certain notes about this webinar, please. Dr. Humayun Ashraf, please.
Professor Ashraf, sir.
He is professor from Aligarh Muslim University. Please go ahead.
Hello.
Yes, we are able to listen you. Please go ahead.
Good morning, sir.
Good evening, sir.
Good evening, good afternoon. So I cannot see the picture on my screen.
Sir, you can speak. No one is going to speak.
Pardon?
No one is going to present, sir. After everyone will present after your speech.
नहीं, हम तो chairperson हैं. I'm not going to present.
आप तो अपने blessings message दे दीजिए.
आप थोड़ा सा 2 शब्द बढ़िया से बोल दीजिए, so that we can start the webinar.
हाँ, that I will do, but I cannot see anything on the screen.
हम आपको देख रहे हैं, आप बोल दीजिए, आप दिखाई दे रहे हैं हम सबको. हाँ, yes.
अच्छा.
Yes.
Okay.
Please carry on.
So I'm starting here.
Yes.
Dear colleagues.
Yes.
Learned speakers, moderators, panelists, and organizers. Very good afternoon. UPSOS has organized this meeting on a very important topic, and that is glaucoma. I am Professor Humayun Ashraf. I am working as in charge Glaucoma Clinic Institute of Pathology, AMU. And in my experience, that glaucoma many times is improperly or very poorly managed, because most of the time what they do that they record the intraocular pressure and then they start treatment, and nobody sees optic disc, nobody sees fundus, nobody sees the automated perimetry, and the management is based only on intraocular pressure. And many times, because for the last 35-40 years I am working in glaucoma clinic, so cases come across, and what I feel it. And in BGO also, few years back, it was reported that 30% of the glaucoma cases were misdiagnosed, and then they are wrongly treated also. So that is the importance of glaucoma. And in this meeting, we have included all the important topics. And in next 1.5 years, our learned speakers, they will speak and they will give a talk on different topics. And I think it will be very interesting. So I request you to keep watching till the end, and definitely you will be benefited from this this meeting. Thank you very much. This is very important.
Thank you, Dr. Humayun Ashraf. We are pleased of your kind words. And I just invite Professor M.K. Singh from BHU. He's a well-known prolific surgeon and very kind-hearted person. We need some blessings from you also. Dr. M.K. Singh.
Thank you, sir. Thank you for good words, sir. The organizers, the chairpersons, the speakers, and all those who have joined this webinar. First of all, I would like to congratulate the UPSOS for organizing this webinar. The topic is very interesting and it is of interest to everyone. Good words have already been spoken by Dr. Dharmendra Nath and Professor Ashraf about the glaucoma. And during the course of discussion, you will come to know all the details of diagnosis and treatment of glaucoma. And I hope all those who are participating in the webinar will be immensely benefited. I offer my good wishes for the success of this webinar. Thank you, sir.
Thank you so much, sir. Thank you very much, sir. So we have special invitees, Dr. Shrikant, Dr. OPSOS Maurya, and Dr. Lalit Kumar. Is anyone there?
Dr. Moria is there, sir.
So Dr. OPSOS Maurya is there. So on behalf of every special invitee, Dr. Maurya can say some few words for us.
Good afternoon, sir.
Yes, good afternoon, sir. Good afternoon.
I think this webinar is organized by in a very beautiful manner by Dharmendra Nath, and with the effort of Dr. Dharmendra Nath and Dr. Deepak Misra, and it is one of the first zonal meeting of
Yes.
UPSOS, and glaucoma is a topic in which most of the cases, sometimes the cases are overdiagnosed and some of the cases are underdiagnosed. So it is one of the very good topic, and I hope with this glaucoma zonal meet, everybody will be enlightened, and I hope this will be one of the very excellent zonal meet, and my best wishes to all of you, and this should be started very soon without any waiting time. So it should be started, sir.
Thank you, sir, so much. So kind words we have from you. So, and hope your blessings will be always with this first webinar organized by UPSOS. Thank you so much, sir.
Okay, sir.
So, Dr. Deepak Mishra, would you like to say some few words?
Just a minute, sir. Dr. Humayun sir has shared his screen.
Okay.
Humayun sir, kindly stop sharing his screen. Host, can we stop sharing his screen?
Stop sharing. Should I stop sharing the screen?
Yes, sir. Yes, sir.
Okay.
Oh, it's okay, sir. Okay.
It's okay.
Good evening to all of you. On the behalf of the Scientific Committee of UPSS, I will invite you all for the first zonal meet of the UPSS.
Still filtering, right?
First zonal meet of the UPSS. We have planned that we will do almost 4 or 5 sub-specialty zonal meets on all the 5 zones for each. This is from the zone 1, and Dr. T.C. Agrawal sir is our executive member for the zone 1, and Dr. Dharmendra Nath sir has planned this on the behalf of the scientific committee. Thank you, sir. Now
Thank you very much.
Start our webinar with the first speaker,
Dr. Richa Gupta.
Dr. Richa Gupta.
Dr. Richa Gupta is a prolific and glaucoma specialist and fellowship. She has done fellowship from Shankar Netralaya, Chennai, and ex-consultant Shroff Eye Charity Hospital, Delhi, and presently taking care glaucoma department at CL Gupta Eye Institute, Moradabad. Welcome, doctor.
Thank you, sir, for the kind words, and I welcome all the delegates to the first talk of the evening. Right. So I have been allotted 2 topics actually. That's Gonioscopy and Tonometry, and I just have 8 minutes, so I'll just try and do justice to both the topics. So let's begin. Right. So I'll be talking a little more in detail about gonioscopy, the basic technique, the practical tips, and the basic aim of this presentation is to encourage ophthalmologists to start doing gonioscopy in their routine practice. So it forms a part of a complete ophthalmic examination, which as all ophthalmologists must be able to perform. What's the principle? Why do we need a gonioscope? That's because the light coming from the anterior chamber angle gets totally reflected internally. And that is why these lenses change the interface from cornea air to lens air, changing the critical angle and thus permitting viewing of the angle. There are two types. First is the direct gonioscopy. An example is Scopes lens, mostly used for goniotomies and EUAs. And the second one, which is normally routinely used in the clinic, is indirect gonioscopy. There are again two types, the Goldman and the Zeiss lens. The Goldman is a little easier, but Zeiss lens is what is used for indentation gonioscopy, and it does not need a coupling solution. That's the difference between the two. When do we need this technique? When we see a shallow angle, when there's a low one helix angle, there is to differentiate between open angle and angle closure glaucoma, and to follow these cases, to look at any angle abnormality in cases of secondary glaucomas, for doing treatment, that is AFT, SFT, to assess the treatment post laser PI or trabeculectomy to look at internal stoma, and during an acute attack of glaucoma CRO to do an indentation gonioscopy. The techniques are simple. First, the procedure is explained to the patient. An anesthetic agent is applied in the eye. A coupling fluid, if indicated, is used, and the patient is asked to look up. The lower edge of the gonioscope is placed on the lower lid, and then with one smooth maneuver, the gonioscope is tipped onto the cornea, and then the patient is asked to look straight. These are the basic angle structures. We just go in brief with each one of them. So first is the identification of the Schwalbe line. That is nothing but the termination of the descemet membrane, and it is seen localized by a corneal wedge. So when a beam of light is projected onto the cornea, the anterior and the posterior part meets at the Schwalbe line. So this orange arrow points at the Schwalbe line. So next is the trabecular meshwork. The anterior part is non-functional and non-pigmented. The posterior part is more pigmented, and this marks the Schlemm's canal, which lies deep to the trabecular meshwork. So this red arrow points towards the PTN. That's the dark brown line that we're seeing. Next is the scleral spur, which is the most anterior projection of the sclera. So this blue area, blue line, blue arrows point towards the scleral spur. And next, the dull brown slate gray band is the ciliary body. So this one is the ciliary body. So what are the aims of gonioscopy? Whenever you are actually seeing a patient in the clinic, there should be two questions in your mind, and the technique should answer both the questions. So the first one is the angle that you're viewing occludable? So what is an occludable angle? It's angle in which the PTM, the posterior trabecular meshwork, is not visible for more than 180 degrees. And this is how you grade the angles, and then the PTM here is what you have to look for. And once you have looked at the occludability of the angle, you have to see whether there is any abnormality in the angle. So for that, we need to indent the angle. So here we see that the angle is closed. Once we are indenting the eye, the cornea, this part opens up. So this is what is the indentation gonioscopy or dynamic gonioscopy.
I just want to interrupt in the between.
Yes, sir.
Have you shared your screen?
Yes, sir. It's shared.
Everyone is seeing his presentation or not?
No, sir. It's
I
shared.
can see.
Already shared.
Okay,
Yes,
it's
sir.
shared.
You can continue,
Sure.
Dr. Richard.
Okay, continue, please.
Right.
Because I'm not able.
I got scared because I'm almost half of the thing.
Because in my I'm not able to see that.
Okay, sir.
Anyway,
Should
please
I
carry.
continue, sir?
Yes,
Yes,
of course.
okay. So this is a clinical picture where. Hello?
No, I am telling Dr. Dharmen to go to the Zoom. He'll be able to see.
Okay. So this is the clinical picture where this shows before indentation and this picture is of after indentation, where the angle can be seen, it's open. This is a peripheral anterior synovial cave, which is seen here. These are iris processes. This is a patient of JOAG with the prominent iris processes. So when you are seeing a patient like this with florid neovascularization of the iris, it's very important to do gonioscopy to look at NVA, and you will find these flimsy capillaries in the angles. So this is a patient of pseudoexfoliation. Again, important to look at the angle to see the highly pigmented trabecular mesh work, and this is Samparese line in front of the sleeve spur. This is a post-traumatic patient where we see cyclodialysis cleft seen here as a white band and angle recession seen here as a dark brown band. Foreign bodies in the angles and iris melanomas. This is the case of Sturge-Weber syndrome. We see episcleral vessel, tortuous and dilated, and there is blood in the Schlemm's canal. And this is a ophthalmic eye with a rudimentary angle, suggestive of a congenital glaucoma. So how should the angle be recorded? Once we actually note the area which is seen, the structure that is seen, we should look at the shape and contour of the peripheral iris. So always make a note whether the iris is concave or convex. Note the degree of pigmentation. It can give a clue in secondary pigment dispersion glaucomas. And note any presence of abnormal or normal structure that is seen. And this is how we record gonio. This is a goniogram where all the things, whatever we've discussed right now, there is a place for it to be mentioned. So I'll come to the next topic, that is tonometry. So the topic which I was given was tonometry, actually applanation tonometry with respect to the corneal thickness. So we'll deal with that and look at tonometry in a little bit of more detail. So GAT is what is used mostly because it's most valid and most reliable, and it does not displace much fluid or substantially increase the pressure in the eye, so it relatively is unaffected by ocular rigidity, and that is why it is more reliable in most of the cases. There is non-contact tonometer. I just included one slide because many of the centers have this now. So it's an air puff tonometry where the applanating force is a column air, which is emitted with gradually increasing intensity, and at the point of corneal flattening, this column is shut off and the force at that moment is recorded and converted into millimeters of mercury. So there are a lot of studies. I've just included one study which shows a relation between the non-contact tonometry and the applanation tonometry. So this is the highlighted the CCT, the central corneal thickness, inside which there is good correlation between the two instruments, which is good for us because most of our Indian population falls in this category. So the higher readings, in case the higher readings were found with CCT, this correlation goes vary. So the NCT records a little bit higher IOP when the CCT increases. So this is a slide which tells the basic things how to avoid errors while doing a Goldman applanation tonometer. So always position the patient comfortably. Otherwise, we'll get an erroneous reading. So the head and the chin should be in contact with the forehead and chin rest, and the lateral canthi should be aligned with the line on the Stefan spring. Always encourage the patients to breathe normally. Many a times when we are actually doing the procedure, they tend to hold their breath. So any Valsalva maneuver will result in an inaccurately high reading. And especially in children, you know, when we are taking a pressure in case of congenital glaucoma, always note whether the patient or the child is sleeping or the child is crying. Because if the child is sleeping, you would get a normal IOP. If the child is crying, it would be a false high IOP. And always loosen tight collars or ties. So for that, you have to actually look at the male patients, how they are behaving. If they're not comfortable with their collars, just ask them to unbutton the top button of their shirts. So these are few of the slides which tell us when we have to look at the readings again and a little more carefully. So when there is an excess fluorescein stain, the Myers would be white and we'll get a false high IOP. Conversely, if there's a less fluorescein staining, Then there'll be thin Myers and the recorded IOP would be false low. So this is an ideal situation where the Myers are adequate and the inner lips are meeting each other. So again, if there is a corneal edema, the readings would be false low, but in case of a corneal scar, the readings would be falsely high. Scleral rigidity, post-scleral buckles, we have to look at the eye a little more carefully because there may be an inaccurately low IOP record. And in cases of more than 3 diopters of astigmatism, again the readings would be false. So this is the most important thing, the central corneal thickness. So now we know that increased CCT will give a false high IOP and a decreased CCT will give a false low IOP. There have been lots of studies. So this is one of the initial papers which is there. This was published in AJO, where they have actually seen this. The thin corneas produce underestimation as much as 4.9 millimeters of mercury. And thick corneas again produce overestimation by as much as 6.8 millimeters of mercury. This table just gives different formulae which have been devised by various people for adjustment of IOP, and this is not to be actually considered. What we need in clinics is this normogram. So this again, normogram is not that if you're seeing a CCT of 505 and if the pressure is 15, then you should write 15 plus 3. That's not actually the thing. So it is just a rough guide about your patient care. So always correlate this with the disc findings and the field, and then try and set the target IOP. Post LASIK. So there have been regression analysis which tells that there is a decrease of 2.9 millimeters of mercury for 70 micron reduction, and Goldman actually underestimates the IOP. Now there are nomograms. The post LASIK nomograms are there where you can actually see and correlate the IOP with the thickness. Again, lot of studies. So this was one study where they have studied the correlation of IOP with central corneal thickness post LASIK. So what they have said is that CCT is an important variable and should be included in assessment of any case of potential glaucoma or ocular hypertension, particularly in eyes with previous photoablative refractive surgery. And that is all. Thank you. I hope I didn't overshoot my time. I think we are taking up the questions at the end of the whole session.
Thank you, Dr. Richa, for your wonderful talk. Our next speaker is Dr. Shalini Mohan. Dr. Shalini is the Associate Professor and in charge of the glaucoma services at Kanpur Medical College, and she is the editor of the UP Journal of Ophthalmology and the Central Zone representative of at GSI. Dr. Shalini Mohan ma'am will speak on the interpretation of Humphrey. Ma'am, please.
Thank you so much, Dr. Deepak Mishra, and thank you, Dr. Dharmendra Nath sir and UPSOS for this opportunity to talk about visual fields in glaucoma. Now we know that perimetry is an important tool for identifying the visual field defects. And visual fields, what are actually they? When we close our one eye and without moving the eye, all the area around which we can perceive is actually the visual field. Now, this is the extent of the visual field, just to revise. Now, because nasally we have the nasal bridge, therefore we can only see 60% of the area. Similarly, superiorly, we have superior orbital ridge, and again we can see only 60%. Inferiorly, we have inferior orbital ridge, but it is depressed than superior orbital ridge, and therefore we can see 75 degree. But temporally, because there is actually depressed area, so we can see wider area temporally, and the visual field is 100 to 120 degrees. Now, whenever we talk of classic description of visual field, the Trocor was the one who actually made us think that what actually is the visual field. So it is an island hill of vision in the sea of darkness. So what does this mean? That if you see the central part of the visual field, the top of the visual field, which corresponds to the fovea centralis, has the highest visual sensitivity. And as we go from the fovea to the periphery, so the visual field starts depressing, the sensitivity starts decreasing, and that is why this is a slope kind of thing which is happening. So basically, visual field is the three-dimensional graphical representation of differential light sensitivity. At some point, the light sensitivity will be very, very high like fovea, and in periphery, the light sensitivity will be less. That is, we will be identifying a stimulus which is brighter. So at fovea, we can identify even a dim light stimulus also. So just correlating with this, now the central part of the visual field, which corresponds to the fovea centralis, is the hill of the vision. Now next to optic disc, where we don't have any rods and cone, we cannot perceive anything, and that is the physiological blind spot. And here we map the physiological blind spot like this. So this is basically a comparison of isopter plot and the three-dimensional plot which has been defined by Tracore. So what are the two types of visual field? One is kinetic, which we used to do in olden days, where like Lister's perimeter and Goldman perimeter, where we took a mobile object. It used to come from the periphery towards the central part of the visual field. And when the object was identified by the patient used to tell us that yes, now we can see. So here the object was mobile, it is kinetic perimetry. But nowadays we don't move the object. We just increase and decrease the light sensitivity of the object. And that is known as static perimetry. And now static perimetry is the standard. So we have two types of perimetry, Humphreys and Octopus. And because most of us are using Humphreys, I will be discussing in detail the Humphreys visual field printout. So the first zone is the test information and the patient's data. The second is the reliability indices. The third one is the numeric data and the grayscale. Fourth one is the total deviation plot. Fifth one is the pattern deviation plot. Sixth one are the global indices. The seventh one is the glaucoma hemifield test, and last one is the probability value. Now let's see them one by one. Now what is there in test information and patient data? First of all, the name of the patient, which is very, very important because we need the visual field in follow-up also. So entering correct name is very, very important. The second one is the date of birth. Now we know that the machine that compares the patient's data with the normative data of same age group, and therefore entering the correct date is very, very important. Third is the type of the visual field which you have done. It can be 30-2, 24-2, 10-2, and then type of the strategy. Initially, we used to do full threshold strategy, which was more time taking. Shall I request everyone to mute their mic? Thank you. So it is a type of strategy. So nowadays we are doing CETA strategy, which is equivalent to full threshold and takes lesser of time also. Then this is the target size, that what size of the target we are using. Giving good refractive correction is very, very important, because if refractive correction is not proper, the patient will note a generalized depression in visual field. So the proper refractive correction is important. Now after this, the second very, very important zone is of zone 2, which is of reliability parameters. That is, how reliable is the visual field. Before jumping on to interpretation, we must ensure that the fields are reliable. So these are various type of parameters which consist of fixation losses, false positive error, false negative error. So what is fixation losses? Now the machine, it assesses that patient has not moved his eye. So if patient has moved his eye, the fields will become unreliable. So nowadays, the lower part of the field has graph like this, which shows the fluctuation, and more is the fluctuation, more inattentive the patient was. Now initially there was another method which was known as Hill-Krikow method, where what machine used to do? Machine used to map the blind spot first, and then used to put targets in the blind spot. In normal case, if the patient does not move his eye, he should not be seeing any light stimulus which is there in the blind spot. But if he has seen the light stimulus in blind spot, that means he has moved his eye. that point is recorded as 1, and similarly multiple times the machine checks. And if it is more than 20 to 33%, the machine automatically maps as a double flag, and that means the fields are not reliable. Now here we can see it is 7 by 13, that means almost 50%. So these fields are not reliable. We need to repeat the visual fields. The second important reliability parameter are false positive responses, where the patient is over enthusiastic, very excited to do visual field. He keeps on pressing the buzzer without seeing the light stimulus and just by the sound which the machine is producing. So here you can see the false positive error 82%. In numeric plot you can see high threshold values. Then there are false positive scotomas, white color scotomas in the visual field, and glaucoma hemifield test shows abnormally high sensitivity. So here we need to explain the patient properly. The next comes to false negative error. That means that patient has already responded to a stimuli, but next time at the same point, a brighter stimulus has been presented to the patient, but patient has not responded to it. So that means the patient has fatigued or has become inattentive and could not respond to a brighter stimuli at the same point of area. So this is a false negative error. Again, you can see this is flagged like this. And then again, there is a clover leaf pattern and the fields are not that reliable. Now, after you have ensured that the fields are reliable, next comes the zone 3, which is the numeric data and the grayscale. So this is the basis of the whole visual field, and in grayscale, you can identify few of the broader scotoma, like a blind spot, or you can see here, you can see an inferior arcuate scotoma. But this just gives an idea to you that what it can be. Sometimes an artifact can be identified in the grayscale, but we cannot interpret visual field on the basis of grayscale. Now coming to zone 4, which is an important zone of total deviation plot. Now what machine does? It actually subtracts the patient's data from the normative data. So whatever is remaining is given in the form of number. Here you can see -5 or -7 number, and then these values, these are changed into probability dots like this. Here you can see, and then you can correlate. Like if you have a black square, that means that it is present in less than 0.5% of normal population. That means in majority of population, this black point will be abnormal. So what this total deviation plot gives us an idea of generalized depression. Suppose patient is having cataract or uncorrected refractive error or advanced glaucoma, you will be getting scotoma in total deviation plot. Then coming to pattern deviation plot. So when the effect of generalized depression is subtracted, then what we get is pattern deviation plot. So pattern deviation plot helps us to identify the localized depression. So if we see any scotoma in the pattern deviation plot, now here we can see in total deviation plot, we have large scotoma in both superior and inferior part of the visual field. The inferior scotoma has reduced and there we have a superior arcuate scotoma. So that means that the superior part of the field is showing superior arcuate scotoma, and in inferior we can see a nasal step and a paracentral scotoma. So that way we can identify the defect in our glaucoma patients. Now coming to zone 6, which is the global indices. Now what are these global indices? These are the number representation of the visual field. So if we add all the points of total deviation plot, now here we can see these global indices. So if we add all the points of total deviation plot and we average it, what we get, that is mean deviation. Similarly, average of all the points of pattern deviation plot is PSD, pattern standard deviation, which is the measurement of, again, a focal deficit. These two parameters are seen in theta standard visual field, but in full threshold visual field, we see short-term fluctuations also, which are deviation of test and retest differences at a particular point in the patient's visual field. And when short-term fluctuations are subtracted from pattern standard deviation, they are given as corrected pattern standard deviation. But now we have only two parameters usually in our visual field, pattern mean deviation and PSD. So now coming to, this is very important one, which is the glaucoma hemifield test. Now what happens is that the visual fields, they are divided into 5 zones in superior and inferior part of the visual field, and they are actually the mirror image. So superior part of the visual field is compared with the inferior part of visual field, and if there are deviation, they are given in the form of glaucoma hemifield test. So if it is normal, you will get the message of within normal limit. If there is difference between the upper and the lower part of the visual field, which exceeds then 99% of the normal population, then it is outside normal limit. If the difference is between 97 to 99%, it is borderline. And general reduction of sensitivity is given if there is generalized depression. And abnormally high sensitivity we have seen in false positive patients. Now finally, coming to what is the criteria for minimal abnormality in our patients. So this is known as Anderson's criteria. Now what is this? If we have 3 or more non-H points which are depressed by less than 5% of on pattern deviation plot, but less than 1%, of which one should be less than 1%, then it is abnormal. Second is if we have glaucoma hemifield test, which is outside normal limit. And third, if we have PSD of less than 5%, but these things should be present in 2 consecutive visual fields of the patients. So to summarize, I would say that we should have 2 consecutive reliable visual fields. We cannot rely on grayscale, but we can have a broader idea. In total deviation plot, we see the effects of generalized depression. In pattern deviation, we see the effect of localized depression, and then we need to look at GST and global indices to totally summarize our visual fields. Then finally, we need to correlate with our fundus finding, because we cannot diagnose the glaucoma on the basis of visual fields only. Correlating with fundus is very, very important. Thank you so much for your kind attention.
Thank you, Dr. Saab.
Sir, you are muted.
Sir,
Dr. Nath, sir, you are muted.
Dharmendra Nath, sir, unmute yourself. Dharmendra Nath, sir.
Now, is it okay now?
Yes.
It is
okay.
fine, sir.
Thank you very much, Dr. Saab. You have given a very wonderful talk regarding this, but I just have 2 questions regarding this.
Yes, sir.
So how can you reduce the false positive and false negative in this?
Sir, actually, in both the cases, it is patients dependent, because it is a prolonged test. Sometimes the patient becomes fatigued and inattentive. So if patient is having more of false negative errors, what we can do? We can explain the patient nicely. We can make him sit and relax and do it after a while. So in a government setup, we can call patient on another date. But suppose patient is coming from far off places, or he is in clinic, we can make him sit for an hour or 2 and again repeat the visual field. For false positive error, the patient is a very excited patient to do everything very correctly. Again, we need to explain him nicely. That when we explain him nicely, we can reduce both the errors on the behalf of patient.
Thank you so much. And one thing more, I want to know, because they are these fields, they are taken to the neurological or disorders also, and the glaucoma. Is there any point of borderline that we can understand that this is the neurological defect?
Yes, sir. What happens in glaucoma, the fields, they follow the horizontal meridian. So if we have a superior arcuate scotoma or a scotoma which is following the horizontal midline, it is a glaucomatous defect. But the neurological field, they follow the vertical meridian. So suppose we have a scotoma which is following the vertical meridian, then most likely it is a neurological defect. That way we can differentiate in both the types of.
Thank you very much for this evening. Nice, telling you all you have completed almost all the things regarding the visual fields. So now next speaker is Dr. Sanchit Gupta is there, and he is a wonderful surgeon. He also deals with the retina and the glaucoma part. Dr. Sanchit Gupta, we are cordially invited to this webinar, and he is a director and the consultant at Netra Drashti Eye Center, Agra. And he is dealing with the comprehensive and the glaucoma fellowship from Nirmal Eye Institute, Rishikesh, advanced emulsification person, and fellowship done from SSNC, Chitrakoot, Medical Retina Fellowship from HB Desai Eye Hospital, Pune. So he has been trained from so many wonderful places. So I welcome Dr. Sanchit Gupta to just carry on for this optic disc examination and conventional and the recent. Please go ahead.
Okay, am I audible, sir?
Yes, of course.
And my slides are visible?
Yes.
Okay, very warm good evening, everybody. I would like to thank Dr. Dharmendra sir for giving me such a wonderful opportunity to speak on this topic and for a wonderful introduction. And it has been always a pleasure working with you, sir. So my topic for presentation today is optic disc examination, which is the utmost important in glaucoma diagnostic. So we are going to talk about conventional and recent advances in the optic disc examination. The appearance of optic nerve head is the single most important clue to the diagnosis and evaluation in cases of open-angle glaucoma. The parameters for glaucoma diagnosis are limited. So once a patient comes to you, you usually have a IOP in your hand, the refraction in your hand. IOPs are non-specific and visual field effects are subjective and delayed. So it is therefore makes sense to look at the optic nerve head and RNFL to examine the structural aspect of glaucomatous changes. The optic disc evaluation, which is the cornerstone in the diagnosis and follow-up of glaucoma patient, may have 90% of specificity and 85% of sensitivity. The appearance of changes in optic nerve head may even precede the detectable loss of vision, as we all know. The 30 to 50% of the optic nerve fibers may be lost before the functional loss may be detected by standard perimetric method. So this is also the one of the criteria, the fundamental for OCT that we will talk later. So probably the most dermatologists will choose optic nerve assessment over IOP and visual field defect if a single examination modality is used, because it is more informative and definitive once you are experienced with the optic nerve examination. The methods, I'll just brush up with the method. So these are probably one of the neglected skills in ophthalmology. So there are 5 different ophthalmologists may evaluate the same disc in 5 different ways and record their impression differently. So we should have a uniform method of assessing the optic nerve head. So we have a uniform consensus about the optic nerve head examination. The methods are direct ophthalmoscopy. The direct small spot ophthalmoscopy may be the one of the best way to evaluate the disc in the glaucoma patient. And it is clear winner if it is a use because economy and availability are considered. It offers magnification, it is portable, red-free light enhances the view of RNFL. But I think the condensing lens and the slit lamp examination with 90D and 60D should be the most standard way of evaluating the optic disc, because using the direct ophthalmoscopy has somehow become the inconvenient for all of us. And most of the glaucoma surgeons will prefer evaluating on 90D or 60D as per their experiences. Indirect ophthalmoscopy is not advisable for the optic nerve examination because the details, the finer details would be difficult to see. So the stereoscopic optic disc evaluation is the most conventional technique to detect and follow the progressive cupping of optic nerve head. And the stereoscopic fundoscopic examination combined for photography should at present is considered to be the gold standard. The technological advances which have come up now are the HRT and the OCT. So let's come to the most important part, which is the how to examine an optic disc and to mark it out that it is an glaucomatous or non-glaucomatous. So first parameter when you look at the optic nerve head is the size, which is the most important. The normal optic head size is 1.5 millimeter, and it can vary from 0.96 millimeter to 2.91 millimeter. The clinical estimation of optic nerve head size, if you don't have a OCT or HRT with you, is possible with the Welcheren ophthalmoscope or WAP 60D diabetic lens, where you can calculate the size of the optic nerve head. The single spot with the Welcheren ophthalmoscope casts a light of 1.5 millimeter in diameter on the retina, which remains constant in the eye with the refractive error between the -5 to +4 diameter. So this could be used as a yardstick for measuring the disc size. As you can see on the left side, we have a disc and the ratio is 0.7 to 0.8. We will discuss further step by step how to evaluate. The size, why size is important? Because your small disc will have a small cup which may hide the damage. What I mean is, if you have a disc which is smaller in the size to less than 0.1, then the cupping of 0.2 to 0.3 may be a significant one. But the large disc, the large cup may cause concern and lead to initiation of unnecessary treatment. That means the large disc have large cup, still it can be abnormal. Small disc with the small cup will still be abnormal if you assess the size and the cupping and the notching. So the size estimation is really important once you are going through for the optic nerve head examination. The neuroretinal rim, it is the most important parameter when you are looking for and monitoring glaucoma, and it should be most highly correlated with the damage. So if you are not properly interpreting the status of the neuroretinal rim, it can be easily over or underinterpreted. So we are going to describe NRR in the 4 subheadings, which are the shape, the area, the volume of the reference level, and the pallor. Coming to the shape, in normal eyes, the rim is width is the broadest inferiorly, followed by superior sector, and then nasally, and finally temporal. So what we call it as an isn't rule. But why our optic nerve head should follow the isn't rule? Because we have a vertically oval disc, but we have a horizontally oval cup. So once the cupping start increasing, the inferior and the superior disc margins are broader, which are the first one to get involved and get thinner. So roughly, what we say is our inferior and superior disc regions are about 50 to 60% broader than the temporal sector in normal disc. So if you can see the diagram where I have shown the outer rim that you have the disc margin, you have to mark it. Then you have to mark properly with the cup margin, and the distance between the two margins will be the rim width, which would be inferior rim width, then the superior, then the nasal, and the temporal. So normally inferior should be greater than superior, the nasal should be greater than temporal, but 85% of normal individuals will follow the zenith rule. You can still have 15% of the individuals which are normal and they just might not be following a zenith rule. So you have to keep this thing another in mind. So in early glaucoma, NRR is preferentially lost with the inferior and the superior disc regions. I told you as the cup is the horizontally oval, and once the cupping starts increasing, the loss of tissue starts increasing, the cupping will start increasing in the vertical meridian. That is, the inferior will involve first or superior will involve first, not necessary, but mostly inferior and superior are involved first. As you can see, we have a 3 clinical photographs. If you can see the photographs which are downwards. There's a low level of glaucoma suspicion as cupping is nearly around 0.4. The NRR seems good. The second one, NRR has started thinning out. There is a notch, we are going to talk about it, and the rim has started thinning. The third photograph is the NRR which is very thin. So the another point which we should assess the NRR is the pallor. It is difficult to establish until well established. It is asymmetrical and found in localized segment of rim. The translucency is used to describe transparent tissue below the blood vessels that have not been displaced backward into notch or thinning of the roof. So maybe suspected, but its validity lies mostly in correlation with the perimetry finding. The acquired pit optic nerve, as you can see in the photograph on the left, there is a shiny reflex. As you can see, this is an acquired pit optic nerve. This is a pathognomic sign of glaucoma damage. It is a localized loss of tissue immediately adjacent to the outer edge of rim. It appears shiny. It does not necessarily indicate that it is a continuing damage, but it is definite sign that the patient has been affected by the process of glaucoma. It is seen mostly with the patient in normal tension glaucoma, which are the most challenging sometimes to diagnose clinically. The notch. I feel personally, in my experience, this is the most important thing that we should always look when we are going to examine the optic nerve. Why? Because it is a marked focal change, and the notch in the rim inferiorly in only one eye, not the other, is highly suspected. Once a unilateral notch is almost never associated with normal eye. If you are seeing a notch, what is notch? As you can see, this is a photograph. There is a loss of localized tissue here, and the cupping has started, the inferior has started thinning out, but in the form of the notch, the thinning has started. So the notch can be complete or it can be incomplete. It is complete once it starts touching the disc rim, but if it's not touching the disc rim, it will be incomplete notch. If you can see the vessel pattern, which I feel is most important, when you see the normal vessel pattern, normal disc, the vessel will roll over the NRR. It will be like lying down and rotating and going away from the disc margin. But if you have a notch, the vessel over here will come and go directly over the surpass the rim. So the asymmetry in rim thinning, asymmetry in disc size. Now it is most important. Now, if there is an asymmetry in the cupping of the two discs between more than 0.2, you always suspect the glaucoma and you want to do the workup. But have you ever thought of the difference in the disc size? Because the first principle I told you was the small disc have a small cup, large disc have a large cup. So if there's a difference between the optic nerve size between the two eye, the cupping which is asymmetrical might not be significant at all. you can get a OCT RNFL done in that patient, can get a visual field get in that patient, it will be normal. The unilateral notch is the characteristic of glaucoma. The disc hemorrhage, as you can see in this clinical photograph, there is a disc hemorrhage which is crossing the rim. It is commonly found in the normal tension glaucoma, and it represents the glaucomatous progression. The CD ratio. Now, most of us as a general ophthalmologist always look at the curve disc ratio, but it has a limitation. What I have been talking about the definitive signs for the glaucoma like notch, but now curve disc ratio, some discs with large curve disc ratio show no field effect, but this disc with smaller curve disc ratio may be associated with marked loss of visual field. As I said, the curve disc ratio omits important signs such as pit, notch, hemorrhage, the sign of disc damage that are related to channeling pattern. It is important when you are considering the concentric thinning. So, in the first photograph, as you can see, the CD ratio is larger, but rims are very healthy. You have an inferior rim, which is broader than superior rim. It is pink and very nice NNR. So, this type of discs are normal. To assess the CD ratio, you have to mark the margin for the cup, then you have to mark the margin of the disc, and you have to calculate the ratio between the two. Like in this particular case, it is 0.2. In this particular case, if you assess the size, it is 0.7. In this particular case, it is 0.9. So small CD ratio with but disc is pathological. Like this photograph, if you see, this is a small disc, right? And the is nearly around, if I would say like 0.3, 0.4, you would be thinking 0.3, 0.4 is not significant. No, the disc is small. This amount of cupping might be pathological. And if you can see in this, there is a notch. There is a notch here, which is leading to the glaucomatous progression, which signifies the glaucomatous progression. So the CD ratio might be misleading. So it is recommended that you do rim disc ratio, which is highly revealing. So disc with moderately cupping requires consecutive disc evaluation and moderately thin rim. So the parameters outside the disc are the chorioretinal atrophy. I believe if the patient is not myopic and if you are seeing peripapillary atrophy, it is an indication of glaucomatous damage. And zone beta is correlated with glaucoma. Zone alpha is often seen in the healthy eyes. The RNFL defect, this is most important. If you are noting down an optic, you are noting down a notch, then you should be noting down the RNFL defect also. So it can be seen with the ophthalmoscope or slit lens 60 diopter lenses. The red-free light is used for detection, and it is a defect in discrete or diffuse. The nerve fiber bundle most visible in the temporal inferior sector than the temporal superior area. This is because the inferior and the superior ones are mostly involved first. The visibility of RNFL decreases marginally significantly with the age, with annual loss of 4,000 to 5,000 fibers per year out of an original population of approx 1.4 million optic nerve fibers.
Dr. Sanchit,
the diameter
summarize because we are getting.
Sorry, yes, sir. The diameter of retinal arteriole. Okay, so I am going to come to the most of the case now. Look at the two discs. It's a patient who presented with normal IOP, and we have a right eye disc photograph and the left eye disc photograph. So as you can see, there is a difference in the cupping, but there is a difference in the disc size also. So the asymmetry of cupping is not significant until unless the size are comparable. So in this particular disc, the size are not comparable. The size of the asymmetry of cupping will not be significant. You can get a OCT done, you can get a visual field done, which will be normal. Okay. Then there's another disc. You look at this photograph. Do you think it is glaucomatous? The CD ratio is around 0.8. Okay, this patient has a 0.7 to 0.8 cupping. This has a very healthy neuroretinal rim. So it's a large disc with large cup, and this is a normal disc. The visual field were normal for this patient. Another clinical scenario. Okay, how many of us can make out that there is a notch? I think there is a very good superior notch, as you can see in this particular photograph, and there's a CD ratio of 0.7. So you can identify the notch, as you can see here. There's a superior notch. The vessels are just coming with the rim, and was correlating with the visual field, and there was an inferior visual field effect. This patient has an IOP of 32 millimeter of mercury. The disc looks like this. It's an absolutely normal disc. The patient was diagnosed to be a case of ocular hypertension. As you can see, the neuroretinal are very healthy. Inferior is greater than superior, no notch, and everything is fine. The visual fields are normal. The disc is normal. So this patient was diagnosed to be a case of ocular hypertension. Okay, this is another photograph we have. Can you, most of us can mark there is a notch here, there is an inferior notch over here, and I want you to see this thing. Can you see the NFLD defect here? Okay, we are going to see in the red field light. Yes, the same photograph in the red field filter, you can see there is an RNFL defect also. So conclusion, about 50% glaucoma is undiagnosed, and in developing country it is about 90%. 50% taking medication, do not need them. 50% do not use medicine. So studies indicate that RNFL defect may precede the detection of visual field defect by approximately 6 years. Thus, early detection and monitoring of optic nerve head and RNFL defects are mandatory. Today, many new technologies have come up like HRT and OCT. Perhaps the information at HRT GDX may allow the combining the qualitative data with visual information and better assess the physician in management of glaucoma. But no matter how advanced the technology will be, it cannot be relied to assess glaucoma progression without corroborating evidence. The newer imaging devices cannot be a substitute for poor clinical skills, and overdiagnosis could be as a result of dependence on newer technology. Correlation with IOP, optic nerve head, NFL appearance, and visual field plus quantitative data contributed is important. And even today, despite this newer technology, gold standard for assessing glaucoma progression will be automated perimetry. So I would just like to conclude in 2 lines. Whatever the optic examination finding may be, it should be collaborating with your visual field. If you see an inferior notch, you should get a superior defect. If your data is not correlating, then you are wrong. You should go back and revise your findings. Thank you. Thank you so much.
Thank you, Dr. Sanchit Gupta, for your lovely talk. Our next speaker is Dr. Vaibhav Jain. He is the postgraduate from the RPC AIMS and at present the in charge of the glaucoma clinic at SGPGI Lucknow. Dr. Vaibhav.
Dr. May I request something?
Yes, sir.
Please restrict the time. All the speakers have to respect the time, please, because the more learned topics are there. They have to also give their talks. So please restrict to your time. I request to all the remaining speakers, please restrict your time. Okay?
Okay, sir. Dr. Vaibhav, please.
Vaibhav, please.
Dr. Vaibhav, kindly unmute yourself.
Good evening to all of you. I will be speaking on primary angle closure glaucoma, which is a very important diagnosis. It is the primary angle closure glaucoma is a relatively less researched topic as compared to open angle glaucoma, as we all know. And the diagnosis is very, very important because the course of disease and management strategy differ from the primary open angle glaucoma. So we all listen about the primary open angle glaucoma more commonly as compared to primary angle closure glaucoma. So I will be speaking on this thing. Is my screen visible? Hello?
Yeah.
Yeah, so it is a relatively, it is misdiagnosed entity. So we do not know exactly what is the prevalence of this disease because we relatively lack population-based studies, particularly in North Indian population, though we have good South Indian studies. So exact prevalence, we do not know of this disease. And it is also having a very complex pathomechanism. The disease course and outcome is also erratic. If you diagnose it is in the early stage, sometimes it is preventable disease. You are but just by doing laser PI, you are preventing patient progressing to the advanced disease. And sometimes the disease course is very rapid and it is a blinding disease. It is a frequent cause of glaucoma. Really, almost 50% of blindness is because of this disease as compared to other glaucoma related interaction. There are a lot of controversies also in this, whether laser PI is effective in all patients, whether laser PI really helps in primary angle closure suspect patients or primary angle closure, or whether the cataract surgery is effective in this disease, whether cataract surgery can be replaced by whether we can do the cataract surgery in place of trabeculectomy. There are a lot of studies have come up regarding this topic, management of primary angle closure glaucoma. So I will be dealing with this Coming to burden of disease, so it is a basically, as we all know, glaucoma is second most common cause of blindness, and we have around 2.54 million patients of primary angle closure glaucoma in India, and currently approximately half of the patients with adult glaucoma comprised of this entity. It is a major cause of blindness. It is twice times than primary open angle glaucoma. It is certain races are more predisposed for this disease, like Inuits, people living near the northern Canada, Alaska, or Greenland. They are more predisposed for this because of their morphological features. And African or Hispanics are less predisposed. We have significant number of patients in India, Southeast Asian. We have to know that there is a 1 case of primary angle closure glaucoma per 10 occludable angles. So relatively, angle closure glaucoma is relatively less common as compared to primary angle closure suspect. We need to know that most occludable eyes do not develop glaucoma. And acute primary angle closure glaucoma is also very rare. It is particularly common in rural population, but in the urban, it is quite rare. And chronic PACG is the most common presentation in primary angle closure. These patients present with the asymptomatic elevation of intraocular pressure. Coming to demographic risk factor, it is very common in 6 to 7 decades of life. Females are more predisposed for this disorder, and some hereditary factor also plays in this. Hyperopia and ocular risk factors are also there, like shallow anterior chamber, decreased anterior chamber volume, relatively anterior position of lens, or increased lens thickness, anterior insertion of iris. Coming to classification of primary angle closure disease according to ISGEO. So the first one comes the primary angle closure suspect, that is angle is at risk. So in this, you just see the structural abnormality in the angle. More than 270 degree of iridotrabecular contact is present, but you have normal intraocular pressure, normal disc, normal visual field, and absence of structural changes in the angle. So this is the primary angle closure suspect, like latent cases in which angle is at risk of primary angle closure glaucoma. Coming to next, it is primary angle closure, in which along with the structural changes in the angle, you have elevated intraocular pressure, as well as you have structural changes in the angles like peripheral anterior synechia. But you have normal disc, normal visual field. So angle is abnormal in structure as well as function. So earlier, these are classified as a intermittent angle closure glaucoma or subacute angle closure glaucoma. Now coming to next, it is a primary angle closure glaucoma, in which along with the structural changes in the gonioscopy, you have elevated intraocular pressure as well as optic disc changes and visual field changes. So this is the last stage of primary angle closure disease. Coming to natural course of angle closure disease like this, PACS progress to PAC, and PAC normally progress to PACB. Coming to older classification, that is older classification is based on the clinical presentation. The latent case are suspect cases in which only occludable angles are present on gonioscopy. And the next is subacute prodromal or intermittent closure, in which patient experience self-limiting episodes of heaviness over the affected eye, along with mild redness and blurring of vision and colored halo. They generally relieved by sleep or exposure to bright light. So you have intermittent episodes of closure of angle, they are relieved by this. So they are equivalent to primary angle closure in the newer classification. In this, you can find the elevated intraocular pressure as well as peripheral anterior synechia or goniosynechia. Now coming to acute angle closure, we all know it is an abrupt and total angle closure associated with severe headache, redness and watering, perspiration, photophobia. These patients require emergency treatment in the line of hospitalization. Mannitol has to be started in these patients, and laser PI is the definitive treatment in these. Now coming to chronic angle closure glaucoma, these patients are having asymptomatic elevation of intraocular pressure along with changes as well. These patients generally behaves like an open angle glaucoma, like light heavy, fully asymptomatic. Now coming to Van Herrick's examination, it is a very simple and valuable tool for angle closure screening, in which we do the grading of peripheral anterior chamber angle. So in this, corneal width is It is generally performed in dark room with 1 millimeter slit limb. So the gonioscopy has already been talked about by Dr. Richard. So I just wanted to show you the short video about the indentation gonioscopy, in which we differentiate between synechial and appositional angle closure. So this is a short video, I think visible to all. So in this we can see I'm pressing the cornea, and as you can see, after indenting I am able to see the Descemet fold and scleral spur is visible. After indentation, it is more clearly visible. So indentation gonioscopy is very, very important to differentiate between synechial and appositional angle closure. So these are the structures visible on gonioscopy. So occludable angles, normal definition is that if you are able to see if PTM is not visible in more than 270 degree of angle, that is occludable angles. And coming to another investigation, that is UBM, ultrasonic biomicroscopy. It is a basically high frequency ultrasound. It scans behind the iris. So very few indication it is having for cyclodialysis, cleft, angle recession, plateau iris syndrome, in which we want to assess the ciliary processes. Another tool, anterior segment OCT. It is a non-contact, better resolution. It also complements the gonioscopic finding. I am not going into detail of this. So we have several parameters of this. Now coming to mechanism of primary angle closure glaucoma, relative pupillary block, we all know there is a one-way wall mechanism from posterior chamber to anterior chamber in which aqueous humor flows. So if during the moderate pupillary dilatation, when the aqueous accumulate behind the posterior chamber and pupillary block occurs, so it creates the iris bombay forward, and the bunching of peripheral iris into the angle closes the angle. So this is basically one mechanism of angle closure glaucoma. Another is plateau iris, in which anteriorly placed ciliary processes causes the obstruction of angle. In this, there is a flat insertion of iris, and the anterior chamber is relatively deep. Now coming to phacomorphic, in which intumescent lens create the angle closure. Now coming to trigger for precipitating pupillary block, there are several triggers like emotional upset, sympathetic stimulation, dim illumination, forward movement of lens, like in reading, changes in body posture, and lot of medications also. Now coming to management of primary angle closure disease. So the bigger question is whether all asymptomatic cases need treatment. So if you are able to see occludable angles in OPD, is there definitive laser PI is recommended in these patients or not? This is a big question to the clinician. So there is one study by Thomas et al. That has been published in 2000. This was a clinic-based series. So they followed up patients of primary angle closure suspect for 5 years, And they found that only 22% of eyes with primary angle closure suspect progressed to primary angle closure, and only 28% of primary angle closure progressed to primary angle closure glaucoma. So there is a relatively lower risk of conversion from asymptomatic to primary angle closure glaucoma cases. Another trial was done, a ZAP trial in Chinese patients. They also found out the low risk of conversion into primary angle closure. So we do not need to do laser PI in all cases, but if you have certain risk factors, then definitely primary angle closure suspect need laser PI. So what are these risk factors? So in some suspicious cases, we can also plan provocation tests, though they are not recommended right now. So a mydriatic test, prone test, darkroom test. If 6 to 7 millimeter rise in IOP occurs after these tests, so this is also strong indication to do the laser PI. So laser PI is definitely recommended if there is established cases of primary angle closure glaucoma in fellow eye. If there is a family history of primary angle closure, if patient cannot come for regular follow-up, if he require frequent pupillary dilatation like for retinal disorder, if he is found positive on provocation test. So these patients are definitely going to be benefited from laser PI. So coming to acute primary angle closure patients. So primary angle closure patients are basically subclinical patients. They also experience the intermittent, they also experience the closure of angle intermittently. And laser PI is definitely recommended in these patients. And if primary angle closure is with high IOP, so they should be treated with medical therapy. Now coming to acute primary angle closure, we all know these patients present with a sudden onset of pain, redness, watering, glare, and they are mostly unilateral. IOP generally rises up to 40 millimeter of mercury. So these patients definitely require the hospitalization, and immediate treatment has to be started in these patients. After IOP come down to 2021, so patient need laser PI in these patients. Now coming to laser treatment of acute primary angle closure, laser PI definitely relieves the attack and prevent the future attack of angle closure. Peripheral iridoplasty with argon laser can also be done if acute PACG fails to resolve with laser PI. Or if in plateau iris syndrome, also laser peripheral iridoplasty can be planned. And the important thing is not to forget the other eye in further follow-up. So one study found that nearly 50% of eyes goes on to an attack within first month if prophylactic LI not done. So there is always a risk of chronic PACG. So follow-up should be maintained 6 monthly or yearly in these patients after attack has been subsided. Now coming to chronic primary angle closure glaucoma, these patients are generally asymptomatic. They behave like open angle glaucoma, but they have to be, we have to treat them aggressively once optic neuropathy induces, because progression of PACG is relatively faster as compared to open angle glaucoma. And laser PI is also recommended in these patients. It prevents the further closure of angle and prevent the pupillary block also. Now coming to surgical management of PACG, most patients need trabeculectomy to control intraocular pressure. Now cataract extraction also widens the anterior chamber angle, and it also lowers the, now the evidence is accumulating from a lot of case series and randomized control trial that cataract extraction is definitely prevent the progression of primary angle closure glaucoma, and it also lower down the intraocular pressure. Now coming to laser iridotomy. So laser iridotomy, we all know before laser iridotomy, you have to give pilocarpine 2% to myose the pupil and stress the peripheral iris, and the laser PI has to be done. You have to search iris crypts, and the tear meniscus must be avoided. This is the endpoint. There are a lot of complications of laser PI that can happen. Now coming to peripheral iridoplasty, very few indications of peripheral iridoplasty like plateau iris syndrome, unbreakable attack of acute angle closure glaucoma. Now coming to role of lens extraction, it is definitely recommended in primary angle closure glaucoma with coexisting cataractous lens. Role of clear lens extraction, definitely not recommended because there is a lot of problem due to loss of accommodation and risk of rare but possible sight threatening complication is also there. Removal is recommended when there are cataractous changes. There is a one study I just wanted to mention it, Eagle study. So it was a global randomized controlled trial, 30 eye hospital across 5 countries. They recruited the patients of primary angle closure with IOP 30 or more, and they found that clear lens extraction showed greater efficacy and cost effective as compared to standard care involving laser iridotomy. So there was some points favoring clear lens extraction in this study. One is that there was reduced need of further glaucoma surgery. That was 1 versus 24. 24 in the laser PI group and 1 in the cataract surgery, lens extraction group. And only 21% patients received further anti-glaucoma medication to control IOP versus 61%. So this was a huge number that favors the clear lens extraction. Now coming to points to remember, the primary angle closure glaucoma forms significant number of patients with glaucoma, and primary angle closure glaucoma is rare as compared to occludable angles. So there is a 1 case per 10 occludable angles. So all patients does not require laser PI. And we have to remember this, most occludable eyes are not going to develop glaucoma. Laser PI is definitely recommended if there are certain risk factors associated with primary angle closure suspect. Chronic PACG may be treated in the line of POAG with medical treatment, but ultimately require trabeculectomy to control the intraocular pressure. Laser PI is definitely helpful in preventing the acute attack in patients with chronic PACG. So all chronic PACG patients require laser PI. Blindness with PACG is more common as compared to open angle glaucoma. So they have to be treated aggressively. Simple Van Herix test on slit lamp also helps to rule out, to diagnose many cases. And gonioscopy, if possible, it has to be done in all cases. It is a gold standard technique we all know to diagnose the primary angle closure disease. Thank you so much.
Very nice, sir. You have given a very elaborated and nice presentation regarding your topic, and you have really do justice with your topic. So now next speaker is Dr. Shweta Tripathi.
Dr. Dharmen, sir.
Yes, sir.
Just announce to everyone to please mute their mics. Dr. Vibha's mic is on, one iPhone's mic is on, 3-4 mics are on.
Yes, please mute all the mics, please. Okay. So after Vaibhav Jain, the speaker is Dr. Shweta Tripathi, but there is a little issue regarding the Mr. Vinayak. Dr. Vinayak is there?
Yes, sir, I'm there.
So can you speak after Shweta Tripathi?
Okay, sir.
Okay. So Dr. Shweta Tripathi, you are the next lens-induced glaucoma, I think so. Is phacomorphic or what?
The lens-induced, sir, totally
yes,
I'll be covering.
Yes. So Dr. Tripathi, please carry on with your lens-induced, and after that Dr. Vinayak will be there because he has to go to the clinic. He has a
thank you, sir.
Certain call out there. So I'm sorry. Okay.
Sir, can I request Dr. Vaibhav to stop sharing his screen so that I can share my screen?
Dr. Vaibhav, can you stop sharing your screen, please? Dr. Vaibhav?
Dr. Vaibhav, your screen is still on, still sharing.
Yes. Now you just carry on, please.
Some members still have not muted their mics. Please requesting all members to mute their mics. Dr. Vibha, are you even on your phone?
Shall I start, sir? So,
Go ahead,
So a very good evening to all. And I would like to thank Dharmendra Nath sir and Dr. Deepak Mishra for giving me this opportunity. And before I proceed further, I would like to again congratulate Dr. Dharmendra Nath sir and Dr. Deepak Mishra for organizing such a wonderful event. So straight away coming to my topic, which was assigned to me today, was lens-induced glaucoma. Let's see that what is the hidden story behind it. So before we go ahead, I would like to just draw attention of all the listeners that actually the burden of disease which is caused by the preventable blindness, that is 80%, out of which cataract induces 63.7. And when we look at the glaucoma burden, that is 11.2 million. But we know that cataract induced blindness is a preventable blindness. But when this cataract leads to glaucoma, definitely it is going to be a permanent blindness. So if timely intervention and a proper correct intervention is done, definitely the preventable blindness can be prevented from becoming into a permanent blinding condition. So defining this lens-induced glaucoma simply in 3 sentences would be, it's a violent secondary glaucoma where the normal IOP and open angle is seen in majority of the cases in the other eye, and there is a prompt relief of symptoms after cataracts extraction in the affected eye. So when we start classifying this lens-induced glaucomas, the broad classification can be into 2 groups. That's a non-traumatic group and the traumatic group. In the non-traumatic group, we are going to basically emphasize and focus on the phacomorphic and the phacolytic glaucomas. So when we talk about the phacomorphic glaucoma, it is the most common lens-induced glaucoma which is seen as compared to the other lens-induced glaucoma, where the basic predisposing factor is the rapidly developing intumescent cataract, probably age-related or probably any form of intumescent cataract, even because of the traumatic penetrating injury. When we talk about the risk factors, they can further classified into 2 groups. That's a confirmed risk factor and a possible risk factor. Confirmed risk factor, as I have already said, that could be age, that is age over 60 years, and axial length less than 23.7 millimeters. Also, as quoted by Ramakrishnan and all, the possible risk factors were the narrow anterior chamber and the female gender predisposition. Now coming to the most important part, that's the biometry. If we want to focus on the biometry per se, the biometry can be working as a simple diagnostic criteria where we can see that these eyes are if the patient is coming to us and the affected eye is having these kind of manifestation, the patient can be warned of other eye having further future symptoms of future incident of this kind of episode. So a further episode in the other eye can be prevented. And what are those biometric criteria? That is lens thickness of at least 5 millimeters and anterior chamber depth less than 2 millimeters. Now, if we want to do the clinical evaluation of these patients, when they have approached us in the clinic, the first most important would be the gonioscopy of the other eye, because this will help us in forming the differential diagnosis, probably differentiating it from the primary angle closure glaucoma. UBM, that is the ultrasound biomicroscopy, that is most important evaluation, because we all know that the zonular laxity plays a very important role when it comes to the surgical decision regarding a combined surgery or a cataract surgery alone. Because if we know that where are the zonules loosened, or probably if we know that this is the point where the zonules are not there, definitely I should say a preventable condition which the surgeon is going to face during the surgery can be prevented by a proper intervention. Now coming to the management, that is the cataract extraction is going to be the definitive management, but with some prerequisites. That is, the eye should be quiet with a controlled IOP, and there should be a pre-operative reduction of a IOP, because we all know that the sudden lowering of intraocular pressure during surgery may lead to suprachoroidal hemorrhage and many more other complications on the table itself. So to prevent all these conditions, the pre-operative reduction of intraocular pressure and the reduction of inflammation is required. So now this is one of the most important slides in my presentation today would be the decision of starting a AGM. That, like our case, is it going to respond to the simple AGMs, or does it need the further intervention? So in cases of phacomorphic, if the presence of peripheral anterior synecdoche is like up to 180 degree or more than 180 degree, there are likely chances that the topical treatment will be insufficient to break the attack. And these are the cases where the ALPI, if the cornea is clear, that is argon laser peripheral iridoplasty is going to work, or a laser iridotomy can be taken into account. But yes, for sure, these are not the pakka or the definitive treatment line, because these are the eyes where the surgery is required. But these are the time-buying maneuvers, I could say, that to make the patient's eye quiet and to reduce the IOP to a certain extent. So now, looking at the surgical techniques, let's have a look over the challenges and how we are supposed to overcome these challenges. Would be the iris prolapse, because we know that the AC is going to be shallow, there is high intraocular pressure, there is positive thrust. So to prevent those conditions, a corneal bipleural incision can be used when we are talking about the phacoemulsification. A positive posterior pressure is definitely going to cause the radicalization of the rhexis. What does that mean? That means the rhexis has got a tendency to run away, and for that we need to do the debulking of the cortex with the help of a 30 gauge needle or probably a 27 gauge needle, which could be fixed over a 1 cc syringe. Now, when the phacotrib is introduced in these kind of eyes, already the cornea is going to be compromised to some extent because of the increased IOP for a longer duration of time. So we need to be very careful for protection of the corneal endothelium. And for that, for the phacoemulsification, what we can do is that we can go ahead and do the soft shell technique. Also, when we talk about the cracking would be difficult because of the loose or the lax zonules. So a alternative of stop and chop or a cratering can be used before we crack the nucleus. Now, when we come to the decision making of trabeculectomy or a combined surgery, that is trabeculectomy with the cataract surgery, the indication for this combined surgery is the synachial angle closure in 3 quadrants or more on gonioscopy, or the second indication for a combined surgery is that the IOP is not controlled with the medical therapy for more than 7 to 10 days. Now, as we know that the importance of follow-up is definitely important in these particular cases, as further emphasized by the study done by Lee et al. And also a very important association is the duration of symptom affects the post-operative best corrected visual activity, visual acuity, as stated by Ramakrishnan et al. Now coming to the second entity of lens-induced glaucoma would be the phacolytic glaucoma, where the presentation is a typical form of an attack of an angle closure, or I should say not the angle closure per se, but yes, definitely the eye is going to be acute red painful eye, one of the DDs, because here we see that there is a diffuse corneal edema. When we look at the anterior chamber, the flare is going to be there. But yes, the clinching form would be the hypermature cataract, because here the pseudo-hypopyon may lead to certain other DDs. The IOP is going to be raised, and yes, of course, the gonioscopy shows the open angles in that particular eye. Again, the management includes of lowering the IOP, making the eye quiet, and cataract surgery is the definitive treatment. But again here, the decision making is going to be dependent on the symptoms. There in the phacomorphic, it was all about the anterior synechy. Here it is all about the symptom, because the angles are open. So if the symptoms are less than 1 week, we are going to take a decision of cataract surgery alone. And if the symptoms are more than 1 week, definitely a combined surgery is going to benefit the patient to a larger extent. Now coming to the, once again, covering over the intraoperative glitches and care. Though we know that the manual SICS strap plus IOL surgeries are to some extent safer in these eyes. But yes, if we want to do the phacoemulsification, the capsular staining can be done with the help of a trypan blue. And always, again, the copious irrigation of AC is really required, because what happens, we all know this pathophysiology, that what the leaking protein material is being eaten by the macrophages, which go and block the trabecular meshwork. So a copious irrigation going behind the iris is definitely required in these eyes to prevent the post-operative spike in the intraocular pressure. If the cataract has dislocated into the vitreous cavity, a PPV along with the lensectomy is going to be helpful. Now, when we talk about the post-operative care, we know that these kind of phacolytic glaucomas, when we do ultrasound, the B scan, that is the ultrasound, we know that some vitreous opacities are there, and they should not be confused with some kind of vitreous inflammation. They are actually those lens particles which have seeped into the vitreous cavity, which resolves on their own within 1 to 2 weeks of time. Also, the inflammation is going to be for a longer time. So these eyes, they require a prolonged course of post-operative steroid treatment. So this was a very interesting case which came across to me when I was going and searching the literature, where a 58-year-old gentleman presented to ophthalmology clinic, both eyes aphakic, and he didn't reveal any history of ocular surgery or trauma, though he said that he had suffered a heart attack in his early stages of life. On seeing the ocular examination over the slit lamp, the anterior chamber showed cells in both the eyes. But when a detailed fundus evaluation was done with the help of an indirect ophthalmoscopy, both the lenses could be seen in the vitreous cavity. So now the tentative diagnosis was made that could be a homocystinuria. How? That's because the patient didn't give any ocular history, but a systemic history of getting a heart attack in the early stages of life. Because we all know that homocystinuria, the patients are more predisposed towards the thromboembolic phenomena. Now, looking at the causes of the glaucoma, which are associated with the posteriorly dislocated lenses, we can see that the phacolytic glaucoma is one of the cause. And this case wouldn't have been tackled properly if the patient wouldn't have given the history of a heart attack. Why I notified this case here? Because that drew my attention. That is, the history taking is really important when we talk about the glaucoma patients or any kind of cataract patients where the ocular findings are not correlating with the history. So this was the case where an interesting aspect of this case was that lens dislocation in both the eyes was associated with the homocystinuria. Now coming to the traumatic lens-induced glaucomas would be further classified into two groups. That's the early onset and the late onset. Late onset, we all know that angle recession is there, but the hemocytotic glaucoma should not be overruled, because we have come across so many cases where after trauma, maybe after 1 month or 2 months, the patient presents with a high intraocular pressure. Looking at the anterior chamber, it is kind of okay. Some minimal flare is there. But when you look in the vitreous cavity, there are khaki color cells. And these particular cases, they require management in a very different way. Early onset glaucomas could be open angle and the closed angle. In the open angle, glaucoma could be because of the direct TM inflammation or the hyphema. Lens particle glaucoma can be there. These are the varied presentation of the traumatic glaucoma, where we can see that the lowermost photograph, that is lowermost, is showing the traumatic mydriasis along with the sphincter tear. If we can see that there is a typical blunt trauma that is showing a rosette-shaped cataract. Hyphema, lens subluxation, or the angle recession can be there, leading to the varied presentation of the traumatic lens-induced glaucomas. Now, just revisiting the hereditary disorders, out of which the homocystinuria, which we have already covered, and I have highlighted here also, that's a very important thing, that the minute we see a case who is having a micro-ophthalmic eye, we need to go and see and talk about the thromboembolic phenomena in these cases. And when we talk about the Weil-Marchesani syndrome, microsphorophakic eye is a clinching diagnosis. Here, when we look at the bottom picture, we can see that these are the cases which show a clear cut, I should say, the lens margin when the dilated fundus evaluation is done. And when we do the gonioscopy, the lens edges are to be seen, thus giving a confirmatory diagnosis of the spherophakic eyes. And these are the eyes which benefit with the help of a laser peripheral iridotomy. And then along with this, these eyes are like, they are not an example that, okay, the surgery cannot be done and PCIOL cannot be implanted. Yes, if managed well, the PCIOL also can be implanted in these eyes. And here, what are we supposed to do?
Kindly summarize.
Ha, sir. Dr. Deepak, but I'll just summarize. So these are the eyes where ubium and ubium, we have to see about the subluxation and the zonal status. The A scan and the B scan needs to be done. These are the cases where we can treat the case with the help of a refractive correction or a surgical intervention, and even cycloplegics can be helpful to the patient when it talks about the lens being displaced anteriorly. The indications for the lens extraction is going to be cataract, corneolenticular touch, and an intermittent pupillary block and the secondary glaucoma. This was the case in literature done by Bhattacharya ji et al., which said that the clear lens attraction and the intraocular implantation can be done in the microsphorophakic eyes, preceded by a ND PI. So now, not going further ahead, since I have been given a warning by Dr. Deepak to finish the time in a case in time. So I would like to just summarize the presentation by a clinical pearl, which we all need to keep in our mind once this kind of lens-induced glaucoma comes in the OPD, that in all these cases, the prognosis depends on the duration of the elevated IOP, the symptoms, because it gives the decision, surgical decisions, whether a plain cataract surgery is required or a combined surgery is required, the extent of peripheral anterior synecdoche, and the optic nerve head damage. Thank you very much.
Thank you, Dr. Shweta, for the wonderful tips you have given. Our next speaker is Dr. Vinayak
Dr.
Bhatia.
Vinayak Bhatia.
He is from Noida Eye Care Center.
Please.
Dr. Vinayak, please.
Yes, I'm ready.
Yes. Kindly share your screen.
Yeah. My screen is visible?
Yes, yes.
Okay, I'll be starting now.
Sure, sure.
Good evening, everybody. I would like to thank the panel for having me. So we will be dealing with the basic aspects of laser PI. To put it simply, the laser PI is a hole in the peripheral iris made by a laser. So what is the aim? The aim is to break the pupillary block. So the indications are mainly the spectrum of primary angle closure disease, that is PACS, PAC, PACG, and acute angle closure. However, we should remember to treat the fellow eye. So here a special mention for PACS, where an absolute indication is to do the PI if the fellow eye has PAC or PACG. The relative indications are the patient is symptomatic, he needs repeated dilated exams, a patient living in the periphery, a one-eyed patient, or having a family history of PACG. The other causes of secondary angle closure glaucoma due to pupillary block, like following cataract surgery with or without IOL, uveitis, and imperforate surgical iridotomy, nanophthalmos, etc. Okay, so the thing is now that the techniques, we're coming to the technique now. The lasers available are mainly the pulse Nd:YAG laser or combined Nd:YAG and argon laser. So the most preferred laser technique is with Nd:YAG, and the laser parameters are mostly kept between 2 to 8 millijoules depending on the iris color or thickness with a single burst mode. It is recommended to use the contact lens. It is recommended to use the contact lens performing the procedure. The two commonly used contact lenses are Abraham 66D and Weiss 1003D. The most widely used is the Abraham lens, which is a modified Goldman type of lens, which has a 66D plano-convex button bonded into the decentered 8 mm hole. While the Weiss lens is more preferred by the experienced surgeons because of its higher magnification and less depth of focus. There are numerous advantages of the contact lens. It works as a speculum, keeping the lids open. It controls eye movements and blinking. And there's a factor of 4, that is the decentered high plus power button creates a heat sink, reducing the energy delivered to the cornea and retina by 1/4. And it increases the energy delivered to the iris by 4 times. Also, there's an optical coating of on the lens, which is like an anti-reflection coating. Also, if there's any bleeding, you can compress the lens to stop the bleeding. Also, it magnifies the target site with less loss of depth, which with increased magnification on the slit lamp. So, coming to the pre-treatment regimen, now there's a lot of importance of informed consent, so that we are explaining the procedure to the patient with the possibility of a blurred vision, headache, brow ache. Second sitting may be required. And most importantly, we are doing it only to reduce the risk of further glaucomatous damage and does not ensure it complete. The damage may still progress after this laser PI. And there may still be need for post-laser medication, and there may be need for further follow-ups. Okay, coming to the actual procedure. So before beginning, with the IOP is measured, we instill 2% pilocarpine 3 times over 45 minutes before the procedure, and brimonidine 0.1 or 0.15% 30 minutes before and after procedure to prevent the post-laser IOP spike. Topical proparacaine 0.5% is instilled immediately before beginning the procedure. Now position the patient. After the patient is seated comfortably at the laser table and topical anesthetic drops have been instilled, the contact lens is placed on the eye. The Nd:YAG laser comes with the helium neon or diode laser aiming beams. So we are basically bringing them all the laser beams to focus after selecting the site, and the slightly decentered posteriorly into the iris stroma. Coming to site selection, so the superior quadrant is preferred as it is covered by the eyelid. The best site being superior nasal quadrant as it prevents injury to the macula. 12 o'clock is not preferred as the air bubbles may occlude visualization of the area, and furthermore this site can be preserved for further iridotomy during a filtering surgery. The earlier they said the site should be between peripheral 1/3, but now they say that it should be as close to the limbus as possible. It is best to target the crypt or an area of thinned out iris and aim the beam within the stroma than on the surface of the iris. So now coming to the, after we've done the laser, we are looking for the end point, or that is the sign of full thickness penetration. That is a cloud of pigments is released from the pigment epithelium. A visible gush of aqueous, deepening of the anterior chamber, visualization of the anterior lens capsule. Okay, there's also another thing in patients who have very thick iris or they are on systemic anticoagulants, then we can do a sequential PI. That is argon laser followed by Nd:YAG. Okay, now coming to this, the preparatory burns are made with the argon laser and they are through the iris stroma until the pigment epithelium is reached. And the preparatory burns, the penetrating burns are made with the Nd:YAG laser. Coming to the contraindications of the laser PI, basically if there's an opaque or cloudy cornea, a widely dilated pupil, flat anterior chamber with iridocorneal touch, active inflammation, rubeosis iridis, a patient who is unable to slit at the slit lamp, or he is not cooperative. The post-laser treatment regimen, as we know, we check the IOP after an hour, make sure to stop pilocarpine, anti-glaucoma medication is continued along with an additional AGM if required, at least for a week, and also add topical steroid drops for a week. The patient is reviewed after a week, where we are checking the patency of the PI, IOP check, and repeat gonioscopy to check if the angle is open, and dilated fundus examination. Now coming to the complications, they're seen in very few individuals nowadays, but as discussed earlier also, post-laser IOP spikes can be prevented by instilling brimonidine before and after the procedure. Topical steroids we are giving to prevent post-laser uveitis. Corneal epithelial defects and burns are seen not very often these days, and hyphema and bleeding are quite common with YAG. So apply pressure with contact lens to stop it. Having come to cataract can also occur. There are focal opacities which can develop, which are usually non-progressive, and diplopia and ghost images may occur if the PI is not covered by the upper lid. To prevent closure of iridotomy, a minimum diameter of 150 to 200 microns and patency confirmed by visualization of the anterior lens surface should be done, and prevent retinal or macular burns by aiming the beam towards the nasal retina. To conclude, the laser PI is a relatively safe procedure to prevent or limit glaucomatous damage due to a raised IOP induced by pupillary block. Thank you.
Thank you, Dr. Watia, that you have given a wonderful talk regarding the PI. Now the next speaker is Dr. Rohan Mehra, and he is a MS in ophthalmology, immediate past fellow from fellow cataract and refractive surgery from Naran Netralaya, Bangalore. Currently in private practice in Chamari Khera, somewhere in Saharanpur is there, and is a wonderful place to see. His place, his residence is just like I'm in heaven. I have seen a few times, and he is doing practice with his father. So he is cordially invited for his next talk, Dr. Rohan Mehra, that pseudoexfoliation syndrome. Dr. Rohan Mehra, please carry on.
Am I audible, sir?
Yes, of course.
Yes. Thank you so much, first of all, Dr. Dharmendranath sir, for those kind words, and Dr. Deepak Mishra sir for giving us this platform to us youngsters who are just out of the academics and have just started our journey in ophthalmology. Thank you so much for including us, sir, with all the stalwarts. So without any further ado, I'll start my presentation and I'll keep it short. Topic for my presentation is pseudoexfoliation syndrome. So I'll start with the introduction. Basically, pseudoexfoliation syndrome or PXF is the most common identifiable cause of open angle glaucoma. When the eye with PXF develops secondary open angle glaucoma, it is called SPXG or pseudoexfoliation glaucoma. There are systemic disorders also involved, and there is open closed angle with zonular instability. Also associated as systemic risk of cardiovascular diseases. Now, going to the epidemiology and genetics, it is more common in older age groups, late 60s and early 70s. Unilateral or bilateral, mostly unilateral, and it is bilateral if it's there for over 20 years. 40% patients with PXF go on to develop PXG. More common in women, but men are at higher risk for glaucoma. Geographically, if we see, it is in Scandinavian countries, mostly Europe, UK, Middle East, and Southeast Asia. There is a high genetic component to it. There is mutation of the LOX1 gene at locus of 15q22. And these codes for elastic fiber components of the ECM. Now, etiology and pathogenesis, there is a gray, white fibrily extracellular material that we see. These proteins basically are produced by the abnormal basement membrane of aging epithelial cells. They are deposited on the anterior lens capsule, the zonules, ciliary body, iris, trabeculum, anterior vitreous face, and conjunctiva. So basically, if we see on a histopathological basis, there is a Christmas tree appearance that is there. That is what is most important thing in this. Polymorphism in the coding of LOX-L1 gene, as mentioned earlier, and essential of elastin fibers. So the current concept in pathogenesis is very simple. There is increased cellular stress along with the oxidative stress, which leads to an increase of matrix synthesis and decrease of matrix degeneration. That is what actually causes the matrix accumulation and causes the pseudoexfoliation to occur. Now, ocular and systemic sources, there are many cell types, so it can be ocular and extraocular sites. So in the ocular sites, it can be on the epithelium, the iris epithelium, vascular endothelium, corneal endothelium, and the Schlemm's canal. Whereas extraorbital sites, the pecs can be seen in extraocular muscles, the septa, posterior ciliary arteries, the vortex veins, and even the central retinal veins. There is a strong systemic association and associated with a lot of vascular diseases, hearing loss, and Alzheimer's disease. Clinical and pathological changes, we see a lot of corneal changes, the pseudoexfoliation endotheliopathy, as to say. So flakes of pseudoexfoliation material are seen or are accumulated on the corneal endothelium. They are diffused or as vertical spindles. They look similar to the Krukenberg spindle. Specular microscopy of the corneal endothelium will show significantly lower than normal cell density changes in the cell shape and size. Now, the ultrastructural studies we see, if we see here, basically you have pseudoexfoliated material adhering to the corneal endothelium and the posterior Descemet's membrane. So the iris changes are basically, you have these specs material, it's called pseudoexfoliation iridopathy. It is present on pupillary margin of the iris with loss of pigment at the pupillary rough. Also, another sign that we see is the iris transillumination typically reveals a moth-eaten pattern that is there, and that is present near the pupillary sphincters. Now, coming to the lens zonules, if we see, it can be divided into 3 stages. One is a translucent stage where the central disc with the occasional curled edges is there. A clear zone is there in the B as indicated in the photograph. And then you have a C zone in which you have a peripheral granular zone, which may be radial striation shape. Cataracts, of course, as we know, occur very frequently in pseudoexfoliation syndrome. Now, also a precapsular film has also been noted. So it's basically into 4 zones. One is the preclinical stage. The second is the suspected exfoliation syndrome. The third is a mini exfoliation syndrome, wherein the first place where we see any exfoliation is the superior nasal quadrant, and then you have the frank pseudoexfoliation. So basically, the place to look for pseudoexfoliation first should be your superior nasal quadrant. Now, pseudoexfoliation material can be seen first, earliest on ciliary processes and zonules. The involvement of the zonules can lead to lens subluxation. PEX aggregates at the origin of the anchorage of the zonules, invades the zonular lamina, which causes instability of the bag. And the cause for this is proteolytic enzymes, which facilitate this zonular disintegration. Now, coming to gonioscopy, you can see trabecular hyperpigmentation. Along with scalloped band of pigment as seen in this photograph, anterior to the Scholtes line and the Sampolosi line. The pseudoexfoliation deposits, they look like dandruff-like appearance is there of these pseudoexfoliated material. And the narrow angles present in some cases lead to an increased risk of angle closure also. Coming to the ultrasound biomicroscopic findings, although it's not available with everybody, but of course it is available in all the institutes. So useful tool to look for presence of exfoliation. And we can basically see this in the peripheral lens capsule in the zonular weakness and breakage, especially when pupil cannot be easily dilated, which is there in case of pseudoexfoliation. The course of glaucoma is very important. So the rise of risk of pseudoexfoliation is 5% at 5 years and 15% at 10 years. Now, majority of the patients have an open angle glaucoma. Mostly it is unilateral. Mechanism of rise in IOP is local production of pseudoexfoliation material and endothelial cell damage of the trabecular meshwork. Now, passive deposition of this PEX material and pigment originating from elsewhere in the anterior segment. This leads to an active PEX production within the trabecular meshwork, Schlemm's canal and collector channels, as well as passive deposition of PEX material within the intratrabecular spaces. This causes a swelling of the juxtacanalular meshwork and gradual narrowing of the Schlemm's canal, leading to glaucoma. So, most important thing in PEX is, of course, we know the IOP runs higher, but the fluctuation of that IOP is very much so there. So, it is more difficult to actually control this than in primary open angle glaucoma because of the fluctuation that is present. There is higher prevalence of glaucomatous optic neuropathy that we see, and their neuroretinal rim damage is also more diffuse. If we see in microscopic that it has been reported that studies have shown that lamina cribrosa has shown elastosis, that is abnormal regulation of elastin synthesis or degradation in the optic nerve head of the patients with pseudoexfoliation syndrome. So also in cases there are acute increase in IOP, so the pseudoexfoliation with open angles may present with also an acute glaucoma. It is actually mimicking an acute glaucoma. It is not an acute glaucoma. But angle closure glaucoma can be there, but it is rare. Mostly there is open angle glaucoma. Zonular weakness is there, causing anterior movement of the lens, thickening of the lens because of the cataract.
Dr. Rohan, kindly unmute yourself.
Increased adhesiveness of the iris of the lens due to the PEX material sphincter muscle degeneration. So what is the differential diagnosis now for pseudoexfoliation syndrome? So the differential diagnosis can be capsular delamination or true exfoliation, a primary amyloidosis, and pigment dispersion syndrome. So coming to the management part, how do we manage it? So it is challenging to manage for the simple reason that the IOP fluctuates a lot in this syndrome. So what we need to do is set a lower pressure target. The target pressure has to be set lower than we set for a primary open angle glaucoma. Medical treatment can be started. That is the same as in primary open angle glaucoma, has already been discussed. There is excellent response to prostaglandin analogs, and there is high incidence of late failure, laser trabeculoplasty, is also advocated in pseudoexfoliation syndrome, particularly effective possibly because of trabecular hyperpigmentation. So the moment you put a hole into the trabecular meshwork, that exfoliation gets released and it gives a pathway for the aqueous to move. So another option is trabeculotomy. It has the same success rate as there is in primary open angle glaucoma. The trabecular aspiration with light tissue contact confirms a short-term benefit, not a long-term solution. It can be performed with cataract surgery or trabeculectomy, and of course the cataract surgery is also a modality of treatment. Now coming to the prognosis, very important. So prognosis here is worse than it is in primary open angle glaucoma. The IOP is significantly elevated and exhibits a greater fluctuation. Patients have to be reviewed every 6 months. With unilateral PXG and PXF in the fellow eye, we have to take care of the fellow eye because it runs a high risk of almost 50% in 5-year time frame of developing it in the other eye. Patients with unilateral PXF beyond 5 years will normally have the other eye at a lower risk. Now, management of cataract. So this is also very important in pseudoexfoliation syndrome. So frequently indicated, there should be a higher than average risk of zonular and capsular breaks. We know that poor pupillary dilatation is there because of synechia formation between the iris epithelium and peripheral anterior lens capsule. Preoperatively, we need to look for phacodonesis, asymmetric AC depth, and endothelial compromise on the UBM may be helpful. Intraoperatively is very important because we deal with a lot of patients having pseudoexfoliation syndrome who we have to operate on for cataract. We need to minimize the zonular stress during nucleus manipulation and cortex removal. So how do we achieve that? To achieve that, we need to make a large capsular axis. We need to minimize the zonular stress. So how that helps is it prevents the capsular fibrosis later. During hydrodissection, we need to tap center of nucleus to decompress fluid pressure on weak posterior capsule. We have a small pupil as we know. So iris hooks, mini sphincterotomies and sector iridectomies can be done. A capsular tension ring should be used to stabilize the capsular bag no matter how you feel that the bag is stable, but still it is better to put a capsular tension ring in the eye when doing a cataract surgery. In the early postoperative period, we need to have a look at the fibrinoid iriditis that may be present and can be reduced by using heparin surface modified IOLs, although these are not very regularly used. So new advances, we know that with the femtosecond cataract that is present now, what can be done is we can make the rexes and the cuts with the femtosecond cataract itself, the laser. How that is going to help is that the manipulation inside the bag is going to be thoroughly reduced because your cuts are already there. You can make 4 cuts or 8 cuts depending, and all you have to do is just go inside with your foot and pull the pieces out. So the stress that you're putting on the zone increases significantly with this. So these are my references that I used for making the presentation, and thank you so much for your patient listening.
Thank you, Dr. Rohan, for all the tips and finishing it on the time. Our next speaker is Dr. Sarita Agrawal. He is the head of the department, Santosh College, and medical superintendent also. Everyone kindly mute yourself. Dr. Sarita, ma'am.
Good evening, everyone. I request Dr. Mehra to please, thank you.
Host kindly iPhone continuously.
Yes, Dr. Sarita Agrawal.
And just a minute, sir.
Okay.
Just a minute, sir. I'm just sharing my screen.
Okay.
By that time, yes, by that time, Dr. Deepak introduce herself.
I already done, sir. Meanwhile, we can ask some questions from the expert panel we have.
Yes, yes.
Dr. Pankhuri is our expert panel. Dr. Pankhuri, are you there?
I think there is no one there.
Yes. No, I'm here.
Yes. Now she is available.
Ma'am, you can ask any question or anything from our previous speakers.
Yeah, actually, regarding visual fields, Humphrey, I am audible?
Yes.
Regarding visual fields, any comparison between the two, like octopus type of this thing and Humphrey? Those two visual field strategies are available. So which one is better? And if she can throw some light.
Dr. Shalini Madam is there?
She is there. Dr. Shalini, kindly unmute yourself.
This question is to Dr. Shalini. I think Shalini has gone.
Tirupati is there. Tirupati can.
Yes, Dr. Shalini is there now. She's, yes.
Yes, sir.
Yes.
Hello.
Yes, sir. What is the question, sir?
Can you throw some light on octopus perimetry? Is there any
okay.
So
octopus perimetry is basically similar to Humphrey's visual field, except few of the things. Like when we talk of mean defect in octopus, it is same as mean deviation in Humphrey's visual field. Similarly, one important difference which is there with octopus and Humphrey's is about Baby's curve. Now in octopus, in place of glaucoma hemifield test, we have Baby's curve, which actually depends on the downfall of the visual field. Now as the visual field decreases, it depresses. There is depression in the Baby's curve. Now if it is within normative data, that will fall beneath in between the two lines of the normative database. If it doesn't fall and it falls beyond the normative database, then it is said to be depressed. And if it is progressing in patients, then it is said that fields are progressing. Rest of all the things are almost similar except few changes in the nomenclature. So people who are using octopus, they are also very happy with it. Except in grayscale, we get a colored thing over there, color scale is there. But basically, I
think this is good now.
one important thing. So it is important that we do the sequential visual fields in the other patients also. Suppose we are doing on octopus, better to do every time on octopus. Similarly, if we are doing on Humphrey's, better to do every time on Humphrey's visual field, so that we can predict the progression of glaucoma in the patients, and accordingly we can treat.
Thank you, Shalini ma'am. Dr. Sarita?
Yes, joining shortly.
Yes.
Actually,
So,
there are some issues in network.
can we take the next speaker? Meanwhile, you can.
Just joining, please.
Okay. Yeah.
Good evening, everyone. Sorry for delay. So I will be speaking about normal tension glaucoma today. So why it is important to understand normal tension glaucoma? As you all know, by diagnosing this disease, you can save an eye from blind.
Kindly make it.
And because
Ma'am,
of
kindly put your slide on slide mode, slideshow mode.
So let me start with the definition. Normal tension glaucoma is a form of open angle glaucoma characterized by glaucomatous optic neuropathy and corresponding visual field defects in patients with IOP usually lower than 21 millimeters of mercury. If you look at prevalence of normal tension glaucoma, it is a part of primary open angle glaucoma as of now, according to today's literature. In 43 to 54 years of age group, prevalence is about 0.2%. In more than 75% of 75 years of age group, it is about 1.6%, and it is more prevalent in female population. For effective management, it is very important to understand its etiology and pathology. As you all know, it is a very controversial topic. So essentially, there are two important factors here: IOP dependent factors and IOP independent factors. In normal tension glaucoma, although IOP remains in a normal range, it can still induce damage to the optic disc. And this has been proven by collaborating normal tension glaucoma trial, which divided normal tension glaucoma in two arms. First is treatment arm. By treatment, they decreased IOP by about 30%. And secondly, by observation arm. And in observation arm, they did not do anything. So treatment arm actually showed reduction in progression of glaucoma. So one thing was clear, that IOP reduction helps, and this is one of the factors causing normal tension glaucoma. Now coming to IOP independent factors, by research, it was came up that the eyes had some structural abnormalities like thinner lamina cribrosa and prelaminar tissues. So they cannot even withstand the normal IOP and causing its damage. And there are other factors like vascular dysregulation, for example, in migraine and Raynaud's, blood pressure and role of ocular pressure, perfusion pressure, and there are some systemic diseases which I will be discussing. So their most important vascular factors are most important etiology in glaucoma. What happens in vascular factor? Either there is reduced perfusion pressure or blood vessels have vasospasm. So it causes reduced ocular blood flow, and that can cause either ischemic damage or oxidative damage. So in this condition, where there is a vascular dysregulation like migraine or Raynaud's phenomena, direct impact on blood flow, so ocular blood flow is compromised. Low blood pressure means low ocular blood flow, so again damage to the optic nerve. There are few systemic diseases like obstructive sleep apnea. In this, mechanical and vascular factors can cause optic nerve injuries. This disease is due to partial or interrupted breathing due to functional collapse of upper airway, causing apnea or hypoxia at night. It induced increased sympathetic activity and leading to vasoconstriction. So the main criteria of diagnosing or diagnostic findings in normal tension glaucoma is IOP is usually less than or equal to 21 millimeters of mercury, open angle on gonioscopy, optic disc cupping with loss of neuroretinal rim, and visual field defects are compatible with glaucomatous cupping. Having understood about etiology and pathology, when we come to clinical evaluation and workup, three broad categorization in your mind should be there. First of all, you have to differentiate it with other forms of glaucoma. Number two, you have to differentiate it with other forms of optic neuropathy. Number three, you have to look into non-IOP dependent factors. So if you have categorized these three things, you will not miss anything. So first thing is history. You need to ask patients specifically about history of pain and decrease in vision. Secondly, history of intermittent steroid use, history of systemic hypertension or hypotension, and some people are in a habit of taking large fluid intake. So that can also cause intermittent increase in intraocular pressure. Then you have to look for factors causing compromised ocular perfusion, like sleep apnea, which we have just discussed. Coming to examination part, you need to look out at visual acuity, color vision testing, full slit lamp examination to give clues about disease, IOP measurements, gonioscopy, dilated fundus examination with optic nerve head and RNFL assessment. The following features may be more frequently seen in NTG compared to primary open angle glaucoma, like flame-shaped hemorrhages, deep focal notching of the rim, and peripapillary atrophy. Optic nerve in normal tension glaucoma is with a large surface area and with thinner inferior and inferotemporal rim, peripapillary atrophy in a crescent or a halo configuration, and peripapillary atrophy is adjacent to the areas of greatest disc thinning and corresponding visual field loss. Disc hemorrhage is very, very important finding where we will get clue about diagnosis of normal tension glaucoma. When you talk about disc hemorrhage, there are usually flame-shaped or splinter-shaped hemorrhages with feathery ends. Hemorrhage is usually within 1 disc diameter with disc margin. Exact cause of hemorrhage is not known. If you look at normal tension glaucoma cases, it is much more than in open angle glaucoma cases. It usually clears in 11 weeks, and recurrence is very important to document. When you are documenting recurrences means the condition is not under control. It is important to undergo certain investigations like visual field testing, perimetry, optic disc imaging, ocular OCT, and 24 hours IOP evaluation. In visual field testing, the defects usually noted in normal tension glaucoma is more focal and closer to fixation. Deep paracentral scotomas are usually noted in initial diagnosis. And corneal patients with normal tension glaucoma have usually thinner corneal thickness than patients with primary open angle glaucoma. Neurological workup is very important to rule out neurological diseases. So you have to look for marks, asymmetry or unilateral optic nerve involvement, color vision deficits, vertical aligned visual field defects, and neuroretinal rim pallor. How to manage a case of normal tension glaucoma? So you have to take clues from studies that 50% of the patient will never progress, and in a patient with progression, treatment will definitely help, and some patient will definitely progress further. So IOP lowering treatment is definitely needed in some patients, and our aim should be 30% reduction, and you can use any of these anti-glaucoma drugs. But choice of treatment will be prostaglandin analog because they have best IOP lowering capabilities. They have very good nocturnal IOP control, and letinoprost have also shown us some kind of neuroprotection. We usually avoid beta blocker because nighttime IOP reduction is really less. Alpha agonists could also be used as they causes decrease in aqueous production as well as increase in uveoscleral outflow. Carbonic anhydrase inhibitor also show very good amount of ocular blood flow and neuroprotection also. So if nothing is working, then there is advice for surgery. So to conclude, I would say that normal tension glaucoma can be challenging to diagnose and manage, but with effective IOP control, progression could be minimized. Thank you for your kind attention.
Thank you, doctor, and really congratulate you for such a nice, wonderful presentation. And this is a very nice topic that you covered all the details of the normotensive glaucoma. Anyway, so now the three speakers, they are left in this evening. One is Dr. Tirupati Nath, second is Deepak Mishra, and third is definitely Shashi Bhaskar from Lucknow. So these, now we have we have diagnosed everything that we have been specialized in diagnosing the glaucoma. Now we need certain things, how to treat the glaucoma. So now there is a medical management, surgical management also. So medical management is to be covered by Dr. Tirupati Nath, and Dr. Tirupati Nath is from Agra, and he is also the joint editor proceedings. Yes, and from Jhansi Medical College, and did his glaucoma fellowship from Shankar Netralaya, Chennai, and was consultant in Chitrakoot Sadguru Netralaya. And right now he's associate professor in SN Medical College, Agra. So many presentations, so many papers all over India and abroad. And I congratulate Dr. Tirupati that I'm proud of you that you are in Agra with us, and I really always take help from you. So please carry on for the management part of the glaucoma, please. Dr. Tirupati Nath. Can you listen me?
Yes, yes, yes.
Okay.
Hello?
Yes, yes.
Yes,
Carry
Dr.
on, please.
Deepati, your voice is coming.
So I'll be starting my presentation. I'll be talking about the medical management. So in this presentation, apart from the pharmacology part, I have tried to focus more on the practical considerations which we require in the medical management of glaucoma. So as we all know, we have a great burden of glaucoma in our country. And in a large perspective, if we see the goal of treatment is, apart from preserving the visual function, it is maintaining the best possible quality of life of the patient which we treat. So when we talk about the quality of life of glaucoma patients, diagnosing a patient with the diagnosis of glaucoma itself has a bearing on the mental well-being of the patient. And definitely these patients have a functional loss in terms of visual field loss and the decreased contrast sensitivity, and there are many so many other things which make them make their day-to-day activities very difficult. And when we treat this patient, there is a lot of inconvenience because of the treatment, the side effect of the treatment, the cost-related issues which are there. So patient education becomes more important, and the patient should always be before starting and even when the patient is on treatment should be educated repeatedly on the chronic nature, blinding nature of the disease, irreversible damage that the disease causes, and what is the value of intraocular pressure reduction in these patients. So when we look at that, what we can do, the therapeutic approaches that we have, either we need to control the intraocular relation of the optic nerve head and the retina, or we can look at the neuroprotection. But with all the research data that we have till date with us, only modifiable risk factor is the intraocular pressure. We can control, or we can just lower down the intraocular pressure, as seen in the various RCTs, randomized control trials like EMGT, CNTGS, or OHTS, which shows that reducing the intraocular pressure reduces the chances of progression of the disease. So what we have is to try to reduce the intraocular pressure with the help of the medical or the surgical management. So in the medical management, the 5 basic steps are to establish a baseline, to set a target pressure, then give the therapy, lower down the pressure, follow up the patient, and if required, modify the target pressure. So how to establish a baseline needs a comprehensive eye examination, including a true intraocular pressure reading with the Goldman applanation tonometry, then a good gonioscopy, optic disc evaluation, and definitely a visual field examination. So what is important to note is that many a times a single IOP reading can be misleading. It can be erroneously high. So we need to take a repeat intraocular pressure reading. Many a times you need to do a diurnal variation test to get the peak value of the baseline intraocular pressure that you are going to treat. And the central corneal thickness helps you a lot in your titration of management, and definitely in ruling out ocular hypertension and normal tension glaucoma. So once you have the baseline measurements, then you need to have a target pressure. Target pressure basically is a range of pressure that prevents the further damage of optic nerve head and visual field damage. So target pressure, it's a dynamic kind of value which depends upon the IOP levels, the baseline IOP that you are looking at, the severity of glaucoma that you are treating, what is the rate of progression of the disease that you are looking at, whether it is a fastly progressing or a slow progressing disease, then definitely the age of patient, life expectancy of the patient. For example, if you are treating a young patient and an old patient with a moderate glaucoma, definitely will be more aggressive in treating the young patient than an old patient of 80 years old age. So when we look at the RCT that we have, EMGT advocates around 25% reduction from the baseline. CGITS, it recommends around 35% lowering from the baseline. But in a broad term, we can say that if we are looking at the mild cases, we can go for a 20% reduction from the baseline IOP, 30% reduction in moderate cases, and 40% reduction in the severe cases. So this can be taken as a rule of thumb and very easy to remember also. So once your target IOP is set, then you are going to start your medical therapy. Now here, there is a very important consideration that the patient, at whatever situation, whatever the severity of glaucoma is presenting to you, his expectation will always be high. So it is not only the knowledge about the drugs and the therapy which will help you. It is the communication and the rapport that you make with the patient How better you communicate the disease process, the nature of the blinding nature of the disease, the chronic need of medication, which will help you in long term. So when you start the treatment, when you know your target pressure, you start with the least offensive drug with the lowest concentration. And if it is a mild kind of glaucoma that you are dealing with, then you can go for a monoocular drug trial. It basically differentiates between the diurnal variation and the therapeutic effect of the drug. In the medical therapy, once you start the medicine, then you have to look at whether the medicine is efficacious, whether it is effective in controlling the intraocular pressure, is it safe, what are the side effects that the medicine is causing, and whether it is affordable to the patient or not. The cost effectiveness and the minimal dosage increases the compliance of the patient and ultimately improve the results. So the other thing that you need to tell the patient is that the patient should have a lid closure or close the lids and do a punctal occlusion for at least 1 or 2 minutes after instilling the dye drop in the eye. And what is more important is to communicate the time interval between the drops to the patient. Suppose you are prescribing beta blocker 2 times a day to the patient, and you will put in one drop in the morning, 1 drop in the afternoon. So what is the fun? So you need to communicate, you need to emphasize that the time interval should be 12-hour gap. Then you should give written instructions to the patient so that he follows it in the correct way, and you get the correct dosage of the disease and a better result in the form of better intraocular pressure control. Even after doing all this exercise, there are very high chances of non-compliance from the patient. Even from the very learned patient, the compliance is very poor. So you have to re-emphasize every time the disease process, you demonstrate the visual field loss to the patient, and you again and again explain the importance of the treatment and long-term treatment, chronic treatment of this disease. So when we come to the pharmacological part, we have the cholinergic drugs like pilocarpine, adrenergic drugs like selective and again non-selective like bramionidine, which is commonly used, the beta blockers, selective, non-selective, then carbonic anhydrase inhibitors, both topical and oral drugs we are using, and then the prostaglandin analogs. Apart from these drugs, there are some systemic drugs like hyperosmotic agents in the form of mannitol and glycerin, which are used to acutely bring down the intraocular pressure in acute situations. So when we look at the mechanism of action of these drugs, the beta blockers, alpha agonists, and the carbonic anhydrase inhibitors, they reduce the aqueous formation. The prostaglandin analogs, they increase the uveoscleral outflow. The pilocarpine, they primarily increase the trabecular outflow. Apart from this primary mechanism of action, most of these drugs, they have a secondary mechanism of action also, which is overlapping. So when we look at the drugs itself, we take a drug one by one. The prostaglandin analogs are the drugs which give you the best 24 hours control, and they give you best intraocular pressure lowering of around 25 to 30% from the baseline with the least systemic side effects. So they are the first line of choice in your medical therapy. Then we have the beta blockers in terms of the timolol, selective, non-selective. The non-selective beta blockers, they give much better IOP control than the selective beta blockers. The only thing is you have to keep in mind that the patient should not have asthma or COPD or a heart block or a congestive heart failure, because this will lead to trouble when you give beta blockers to such patients. Alpha agonists can be given. Alpha agonists, they also give a pressure reduction of around 20 to 25% from baseline. The most important side effect is the allergy that we get from this, and it also causes CNS depression, so it should not be used in kids and very elderly patients because it can cause significant CNS depression in these patients. Carbonic anhydrase inhibitors, oral, they have a better control of IOP, around 25 to 30% lowering from baseline, while the topical drugs, they have a 15 to 20% of reduction from the baseline. And cholinergics, not commonly used now. They have a good role in primary angle closure disease, but not in the open angle closure disease, open angle disease. So the pilocarpine is the last choice of drug while you treat an open angle glaucoma patient. So when you aim at a 20% reduction from baseline, you can go for beta blockers. The only thing that you have to keep in mind is that the patient is on systemic beta blocker for hypertension, then probably there will be a crossover and the drug may not be so effective. So it should not be used as a primary or first line therapy in the hypertensive patient on systemic beta blocker. When you need a 30% reduction, go ahead with a prostaglandin if there is no contraindication for the use. The first line therapy usually is a prostaglandin analog nowadays because of the better 24-hour control and the least systemic side effects than beta blockers, and if at all both of them cannot be given, then we can go for an alpha agonist. Second line any of these drugs can be used as a second line additive drug to the first line drug. When we look at the prostaglandin analogs, bimatoprost has shown a better IOP control when you compare it with the travoprost and the latanoprost, though the amount of hyperemia caused by bimatoprost is also slightly high. So if we see the IOP lowering effect, bimatoprost gives around 33% lowering of IOP from the baseline. One of the important thing is to note is that if there is no response with one prostaglandin analog, then we can switch between the prostaglandin analogs and sometimes it works. So you need not to change the class of drug. You can change in between the prostaglandin analogs also. So beta blockers, definitely they are more commonly used drugs because they have been there for a long time and they are economical. So I'll be skipping this part. So when we need a reduction of 40% or more from the baseline, no single drug will give you a 40% reduction, and you need to have a combination of drugs. So you need to keep in mind when you are combining two drugs, the two drugs should be of different class. Their action should be different, the mechanism of action should be different. Only then you will get a more reduction in the intraocular pressure. We have got many options of combination drugs like beta blocker with alpha agonist, then beta blocker with carbonic anhydrase inhibitors, then carbonic anhydrase inhibitors with alpha agonist, and beta blockers with PG analog. All are available in the market. So to sum up the medical therapy, to start with, as a first line therapy, we can use a PG analog, beta blocker or alpha agonist, whichever you want. What you need to see is whether the drug is tolerated and whether it is effective in controlling the IOP according to that class of drug. If it is effective and if it is tolerated, then you look at whether the target IOP is achieved or not achieved. If the target IOP is achieved, then probably you can go ahead with the treatment and just keep the patient in the follow-up. If the target IOP is not achieved, then you have to add a second medication. When you add a second medication, you have to keep in mind that the mechanism of action of the second medication should be different. And again, you have to see whether the second medication is tolerated and is effective in controlling the IOP further or not. If not, then you have to again add a third medication, or you have to look at other options like surgery or laser. What is more important is the follow-up period. So each time the patient is coming to the follow-up, compliance should be checked. Check the drugs. Ask the patient every time to bring the drugs with him. Check whether he is putting the drug in the right frequency. Ask when he has put the drug last time. And if possible, sometimes check how the patient is using the eye drops. Then you look for the side effects. Ask the patient what difficulties do he have instilling the eye drops. Then you check for the effectiveness, whether the IOP is being reduced with the drop or not. Once everything is done, then you see whether the disease is progressing or not progressing. If the disease is stable, it's okay. If it's not, then you have to reset your target pressure. The most important thing is that the most of the anti-glaucoma medication, they do have side effects in the form of ocular surface disease. And it is not the primary drug itself, it is basically the preservatives which are more harmful in the form, and most commonly used preservative with the anti-glaucoma medications is BAC or benzyl cholium chloride. So the answer to this is that we can use the anti-glaucoma medications with the safer preservatives like SOC, Purite, Sofzia or Poliquat. If we talk about the newer drugs, there are many things which are in pipeline, but what we have nowadays is the Rho kinase inhibitors or ROCK inhibitors by the name of ripasudil or nitasudil. They also work at the trabecular meshwork. They do slight modification or remodeling of the trabecular meshwork extracellular matrix. They clear the spaces between the trabecular meshwork and increases the trabecular outflow and decreases the intraocular pressure. It is also shown to cause decrease in the episcleral venous pressure and thereby helping again. Neuroprotection, if we talk about neuroprotection, it is a topic more in research. There are many entities which have come up, but none has shown any promising results. So neuroprotection is not for now. What is most important is that you have to increase your chair time for the glaucoma patient. Give ample of time to the glaucoma patient, give written instructions, give information booklets. Do give time for patient education and the education of the relatives, because it is ultimately your approach that will make the patient to go ahead with the treatment and to come for follow-up. Otherwise, he'll be lost. So in the end, if still the IOP is not controlled, disease is progressing, go for either laser therapy or the surgery which is required. And we should realize that we have our limits. We cannot treat each and every patient. We should take second opinions. And it is not only the drugs which are important in your therapy, it is your compassion and your empathy to the patient, which is more important in treating a disease like glaucoma. Thank you.
Thank you so much, Dr. Tirupati Nath. And one thing I just want to know, okay, how frequently you ask the patient for the follow-up?
A very nice question. Basically, it again depends upon the severity of glaucoma that you are seeing. To start with, when you see a patient on the very first time and like you are making a fresh diagnosis of glaucoma, then probably you must want to know whether the disease is progressing fast or whether disease is progressing slow. Once it is established, then maybe you can delay the follow-up a bit longer. But when the disease is severe, you need to see the patient every 2 to 3 months, because when there is a very minimal visual function left, then it is a responsibility to see the patient more frequently and to be slightly more aggressive in treating those patients.
So do you recommend that this visual field should be repeated every time, or 6 monthly or quarterly? What
it again depends upon the severity of disease. If it's a mild glaucoma, then maybe once a year is sufficient. Okay. After a first few fields, if it's stable, then once a year. If it's a severe patient, maybe after every 2 or 3 months, it should be repeated.
Thank you very much, Dr. Tirupati Nath. You have given us such a wonderful presentation, and हमको पूरा आपने treatment सिखा ही दिया. बहुत बढ़िया रहा. It is nice. And now the second other speaker is Dr. Deepak Mishra. And Deepak Mishra के बारे में जितना भी कहा जाए उतना कम है. Deepak Mishra, can you listen me now?
Yes, sir. Yes, sir.
Okay. So he is presently working as an associate professor in Regional Institute of Ophthalmology, BHU. And he has won so many awards, so many gold medals, not medals, at least 15 gold medals, they are in his name. And so many books in his name, publications, 65 publications and articles are there, including 35 international. And research and review, editorial, and so many things all together. There is a huge list of, I can see this, and presented as a guest speaker, 105 presentation at the various national and international platforms. Recently, he has been to Egypt for SICS, and there he opened a chapter there. And right now, he is the chairman scientific committee of UPSOS. And joint secretary of MICS Society, national convener of SSTC, founder PG Examination Forum. So welcome, Dr. Deepak Mishra. I have given a very short note regarding you, but you have a book of introduction, exactly. So welcome, Dr. Deepak Mishra, to our webinar.
Thank you, sir, for your wonderful and kind words. Without more delay, because we are going late, I am just coming to our topic. My topic is glaucoma drainage devices. There is no financial interest in it. What happens? Glaucoma drainage devices are the implants which creates an alternative pathway of drainage from the aqueous, from anterior chamber to the subconjunctival or supraconjunctival space. It's most kindly mute everyone. Most kindly mute everyone.
Who is speaking?
अरे
पानी मत मिलवाइए, यहाँ ड्रेनेज डिवाइस की बात हो रही है, कौन पानी मिला रहा है?
Most kindly mute everyone.
Who is? I think Vikas Singh is not unmuted. Mr. Vikas Singh?
Suggest.
Yes, now he is muted. Carry on, please.
Yes, in 1907, Rowlett gave an idea that we can, by draining the hypopyon from, in an acute case of the congestive glaucoma, that something is drained from the anterior chamber, and after that there were the many modification innovations came to treat the refractive glaucoma by draining the aqueous from anterior chamber to some other spaces. Then general and one line indication for the glaucoma drainage devices is the refractory glaucoma, but it is used in all the types of glaucoma where it is not possible or medical therapy fails, like the neovascular glaucoma, uveitic, and particularly in infantile and juvenile glaucomas. What happens when we implanted a device inside the eye? Then this device plate forms a fibrous, non-fibrous plate surrounding it. This is a space where you can find out that this is the plate of the device, and this is a non-fibrous capsule. It is a fibrous capsule formed surrounding the device, and gradually this aqueous first pulls down into this space, and then from there it diffuses into the capillaries and lymphatic. So there is different way that we have to know important that if fibrous membrane which is non-adherent in nature formed around the device, which provides some restriction and the pooling of the aqueous before it drains into the capillaries and the lymphatics. These fibrous capsule at the end of the plate offer some resistance for the drainage, and it has been observed that the IOP reduction by these type of devices depends upon the capsular thickness, how thick the capsule is formed at the end of the device plate, and somewhat it was thought that it also depends for some extent up to the surface area of this plate. But in the RCTs and different studies later on proved that up to the some limit of increasing the plate size, we can have more aqueous drainage, but after some limit size, we cannot increase. So this thought that when we increase the plate devices or the number of plate or anything, we can have more drainage. It is limited up to the certain cases, not for the all. And previously scientists also used some antifibrotic agents to enhance the drainage. But again, in the various RCTs, and it was clear that there is no clear-cut effect of antifibrotic agent when it is used with the devices. Now the classification, it is broadly classified into the non-valve devices like the single plate Molteno device, then valve devices, and some variable implant or the restrictive implant devices. Based on the classification, it is also classified into the anterior subconjunctival, means the place where these devices drain out in the anterior subconjunctival, or the posterior subconjunctival, or some another places. These are for the history purpose, not used much. One is the Muscati device, in which the aqueous is drained in the lacrimal, and another one like Rolette and certain externally. Ahmed glaucoma valve. Now coming to the Ahmed glaucoma valve. It is a simple polypropylene devices available in different size and models. It depends upon the which size is used for the pediatric and which is for the adult. And second difference is based on the material. It is some of the devices are made up of silicone and some are made up of polypropylene. Also, it is important to note that all the AGB devices are the valve device. Another one is the Bartlett BGI. These are the non-valve device. Here you can see the end plates are made up of some fenestrations, like here we have seen that these fenestrations, and it's whatever the aqueous drain will drain from these the fenestration. And next is the Cuprin slit valve. It is again in devices in which is having, you have seen this a elastic disc type of surface attached with it, and it contains an horizontal and vertical slit in the unidirection. So here you can see this slit can go and drain the aqueous. Then MDI, or the Molteno implant, it based on the fact that increasing number of plate area or the surface area, we have more drainage. So it is either the single plate device or this is, you can see here, the double plate devices in which two plates are formed. One plate is having the surface area of 134, and when we combine the both plate, then we have the surface area of 268. So initially we got that from one plate to two plate have better function, but further on, up to some extent, increasing the plate size, the aqueous drainage is more, but it is not true for very large size devices. These are some of the new MIGS devices came into the market, hydrous implant, T-cent, everything. I'm not going to tell about them in the detail because Dr. Bhaskar is going to cover it with TRAB and MIGS in the next topic. Now, one important is the pre-operative assessment and implantation of these drainage devices. From my side, three things is important. One is the mobility or the access of the conjunctival, because whatever the device we are going to place, it is inside the conjunctiva. Second one is the anterior chamber depth. Always have some anterior chamber depth, because when the tube is placed inside the anterior chamber, then it should be like such that it neither touches the cornea nor touches the iris. And third one is that you have to know find out what are the risk factor or high risk factor like neovascularization. But at least two things is important. One is mobility, anterior chamber depth, and the synechia, whether it is peripheral, it is synechia or not. Now coming to some important step, I am going one by one in the device form. One important step for implanting this is the priming of this wall. This is very important because we have to inject some visco from this valve. Here is the valve, and through the 26 gauge needle or the syringe you have to inject, so that you can prime that there is no air or nothing is left. And before implantation, check that valve is working or not. Second one is the placement of valve. It is very important that you have to place the valve from the limbus 8 to 10 mm. If it is too near towards the limbus, then it will lead to the scarring or the failure. And sometimes this plate or of the valve, this plate of the valve is disturbed by the or lead to the rubbing of the eyelids. And another one, to prevent its migration or the loss from one place to another place in the subconjunctival space, we have to suture these plates. These plates are the sutured with the suture to make it fix. And when we are going to, believe me, this is the only step which is slightly or more difficult and required more practice when you are going to inject the Ahmed glaucoma valve or any device, is the entry into the AC. If you have some another donor or implant, then you can directly go with 26 needle and insert your tube inside, or just like TRAB, you have to create one partial scleral flap and insert the tube with inside it. This is the flap I have created, and you can clearly see in that after making the fornix based flap, we have sutured here. Here is suture is there, seeing, and device is inside the tunnel, and after that you have to put it some scleral patch there. And this is the tube placement, which is very important, that you are seeing tube is up to 2 to 3 mm of the tube is inside the AC, and it is such a way that it should not touch, neither touch the cornea nor touch the your iris. Otherwise it will lead to chronic uveitic and endothelial damage. And the graft closure, after putting all this, you have to close the graft by the different sutures available. And this is a post-operative phase, which is very important to know about these devices. Sometimes even in the wall device, there is an hypotensive phase, means starting 1 to 4 days, the IOP is usually low, and the bleb you have to notice is small and diffuse. It doesn't mean your device has failed. You have to know that it is a hypotensive phase, and sometimes even in the non-wall device, you have to reform the AC next day by putting some high viscoelastic and other thing. But after that, when it forms, going to form a non-fibrous plate around this device plate, then the IOP is slightly high, and the dome is, bleb is inflamed and dome, and this is known as the hypertensive phase, in which the IOP increases. And after, you have to know at the end of the hypertensive phase, there is a stable phase where the dome is again bleb is the dome shaped but non-inflamed. At this time, the IOP is in the middle of the teens, and this is the stable phase you have to notice at the end of the 4 month. And the post-op or the intraoperative complication at the time of 2-3 things is important. One is the bleeding. Another one is the difficulty in insertion. As I already mentioned, this is the most difficult step in this device to insert the tube inside the AC and anterior chamber collapse. And early post-operative is rise in IOP, corneal compensation, sometimes tube blockage is there. And late post-operative complications, that is because of the tube and plate erosions and sometimes the displacement. Sometimes sterile hypopyon is also noticed. Thank you. Thank you, sir, for giving me the opportunity. Next is.
Thank you, Dr. Deepak.
Yes.
Very nice illustrated talk about the glaucoma drainage devices. And probably we have left with only one speaker, Dr. Bhaskar, sir.
Yes.
Please introduce. Dr. Deepak.
Yes. Dr. Bhaskar is,
yes.
is going to tell us about the trabeculectomy and the MIGS new surgeries about the glaucoma. He is the associate professor in the Department of Ophthalmology at KGMU. Bhaskar sir, kindly share your slide.
Okay. Good evening, everyone.
Good evening, sir.
And so now I will just talk about this glaucoma management. Can you see my slide now? Hello?
Yes, sir. It's visual.
Okay, okay. Okay, now I think it's not full screen. Okay, now. Okay, so now I will talk about this glaucoma management, the surgical part. No financial disclosure to be made. Now we know glaucoma, so from early last century it has been pressurized. So I will skip these slides now, coming directly to the trabeculectomy part. Now the management of glaucoma can be medical, surgical, or by lasers, as it has been told by previous speakers. In surgical, it can be this filtering surgery, which can be penetrating and non-penetrating, and MIGS. There's minimally invasive glaucoma surgeries now. Most common is the trabeculectomy, is the most common one. Now, the main mechanism is from the aqueous comes through the posterior chamber, through this PVI, comes into the antechamber, comes through this defect which we make here, and comes subconjunctival and is drained out, and subconjunctival and is absorbed by the subconjunctival vessels and episcleral vessels. It has success rate of 71 to 98%. Failure is due to the subconjunctival fibrosis. So modifications have been done in trabeculectomy. This can be by medications and sutures. Medicals can be by steroid, perfluoropropane, metabolite like mitomycin C and FE5FU, which we do nicely then frequently now. Collagen cross-linking inhibitors like D-penicillamine and aminopropyl nitrate. And by sutures, we can do by eligible, adjustable, or suture lysis. Why these have also been mentioned in the literature, like beta radiation, amniotic membrane, photodynamic therapy. Now, recently it has been by anti-VEGF, which can be given intravitreal, intracameral, subconjunctival, topical. So I will come for the trabeculectomy. This I will show a video here. So can you see the video? Is it visible? Can you?
No,
not visible. Just let me again share that. This is share part. Okay, now. Okay, now just wait. I'm here. Are you getting now? Oh. Okay, this one. This, let me start from beginning here, this part. Okay, now in the typical, we just take the traction switcher here. Now this I am taking the traction switcher. Now this traction switcher can be with the superactus muscle or with the cornea also. So here I have taken the cornea switcher which will act as a traction. And now I just pull it down. And now after this, I make this here. Now this I will do a paracentesis. This is tied down. Now I do paracentesis for slow release of pressure because sorry, I going off. Sorry, some technical problem is there. Just bear with me.
You can skip this video, boss. If
no, I think it can be there fast.
Okay.
Because I will do it fast. I think now. Are you able to see now?
Yes.
Yes. Now after making that, this connector, incision can be limbal base or phonic base. Now this is phonic base here. Now I fast forward this here. So now this has been made. Now this is what I measure. Now this are the crescent which I do. A nice technique, pause it here. So now this is about 3 mm. We know this is crescent 3 mm to 3.5 mm, and the incision of the black has to be 3.5 mm to 4 mm. So I just measure roughly with this, or we can measure it with the calipers also. So I must just measure because I will make a crescent with this here. So this is about 3.5 mm to 4 mm. So I will make a conjunctival just here. So let me fast forward this now here. So now quartile. Doing the quartile from meters now. Let me fast forward this. And now this is 300 micron blade which I use now to make a partial incision of this superficial flap. So this is 300 micron blade which I use because it has got a guard here. And now I make a pocket just like a SACS tunnel we make here. Just like pocket in a tunnel, like SSS looking forward. Yes. Now this is the pocket coming up to the cornea here. Tip can be seen here. Yeah, this is the pocket still forwarding here. And now I cut the edges, 2 edges of this here. The pocket has been now superficial flap will be just separate now here. I cut these 2 edges here, and so superficial. And now here we can see this clear cornea, and this is the blue zone, and this is the white zone. And incision will be made here, from here. So from here to here. This is blue zone which I am pointing out. This is different color. You can see this transparent cornea, then blue zone, and white scleral zone is here. So incision has to be made here for the inner ostium. So this is I am making an ostium here. So these are 2 ostium. Then I will cut, take out this portion of this here. Okay, so this was wrong. This was I was named trabeculotomy also. This was small baby child. So here I put this trabeculotome and just make it inside. So this was trabeculotomy both. So just forwarding, and now I just remove that. I think I'm going to forward here. Okay, now this is the one here. So this is the scleral flap, deep flap, which I wrote now. And you can see this iris coming, and now I will do iridotomy here. Just pull it out and just in one go. So this is the iridotomy which I done, and now I will just tie the sutures here. This both ends. So yes, so one end is here, tie here. This then. So after one end here. Now the same flap I will do here on the other side. And now this is other side, I am just tying the knot. So this was phonic base, conjunctival, and this was square shape. Both items were cut. This inostomy was made, and iridotomy was made. And now I'm just closing the conjunctival part. So this was very short time. So time allotted was very less. So this was the part. So now I will do this here. So now another part which I will now sorry. So now before going to images, let's see. Are you able to see now slides?
Yes, sir. Please continue.
Yes, now that was development, and now aqueous dynamics. Before going forward, let me see what is aqueous dynamics. Aqueous comes from the ciliary body, comes in the posterior chamber, comes to the pupil and drains out. This, you know, this another picture coming here, and just now this I am telling because this aqueous comes here. This is trapezium archwork, and this is Schlepp's canal. Aqueous comes from here and comes through the collector channels to the subconjunctival space here. Another pathway is through the uvuscular outflow. From here comes again here between uvea and sclera. Then again it comes to the collector channels and comes out. So we are using this in microincision glaucoma surgery here. So this I will tell now. This is another. So this is the aqueous drainage, ciliary body, posterior chamber, Schlepp's canal, interscapularis channel, episcleral plexus to cavernous sinus. This is so this is one, and this is the pathway how it comes to the episcleral plexus, comes to the space after vein and comes to the collector channels to this venous circulation. So images by stents, spans, cypars, arrows, all these are images implants here. So how to remember them? So this is what I told you. This was part here. Aqueous comes from here to this Schlepp's canal, drains down in collector channels, and come through the subconjunctive space here. Again from uvuscular comes here. This is supracortical space here, and this is subconjunctive space. So these can be used, and these surgeries can be done ab externo, that means from outside, or from inside. Ab externo means coming from outside this thing, and from inside is ab interno. So subconjunctive filtration, that is aqueous has to come here. So it can be Zen implant or it can be express implant. This I will show here. Then enhance the subconjunctival space here. This subconjunctival space here. This is simply of Zen implant here coming here. This is ab interno. From here, this implant is coming as shown by the speaker. So this implant comes into subconjunctive space from the antechamber. So this is the detail here. From opposite side, 180 degrees comes here. from the angle into subphalanx, and now aqueous drains from antechamber to the subphalanx space. Going. Now this is ab external from outside. These are stents which are implanted from outside. This is flap, this color flap from outside. And this is implant here. So this is a blab and drains out from here like this. Now it has Slem's canal. Now we can use this Slem's canal for enhancing. Like just this is hydrus, which I told by Deepak here. So this is from ab interno coming from here, going into the Slem's canal, and now this aqueous drains to the subphalangeal spaces, drains out here. And there's another trabeculum again from ab interno. We just move this surface of the trabecular meshwork here. So this aqueous goes directly into subphalangeal space, and then it drains out here. Then from ab interno of the Slem's canal, ab interno we can go from here. This is again from here to draining here. This draining out, removing this surface of this trabecular meshwork, and then goes inside here. It is here. This implant here. Then ab externo from outside, that we come from this dilated pipe going from outside to the Slem's canal, and then this is made patent here, dilated pipe, and this is canal, visco canaloscopy or canaloplasty. This is done here, very enlarged. Supracortical space here, like ab interno again we see this is another implant. This bypass implant come from here, put here in this supracortical space. So from here it comes to this interstitial channels and then drains out here, like this it is shown here. Supracortical space. UPSOS outflow, increase the UPSOS outflow. Then the ab externo, this is the implant which we implant from outside. This is Solex gold shunt, which is implanted from outside here. The supracortical, another aqueous shunt which goes from outside. This is ab externo. Now another thing which we can do is also part cyclodestruction, which we go ab interno and cyclophotocoagulation. This is ab externo from outside, cyclocryo or cyclophotocoagulation. These are all manner. So these increase the outflow in the subphalangeal space, enhance Slem's canal, supracortical space, and decrease in proliferation by cyclodestruction. So again, just to advise, we use these cases, that is subphalangeal filtration, enhance Slem's canal, filtration, supracortical, and cyclodestruction. Both can go from outside and inside. So thank you. I think I passed my time. Okay, thank you.
Thank you, Dr. Bhaskar, for your wonderful talk. Now it's time to finish, and at the end I would like to thank all the speakers, our panelist Dr. Pankuri and another one, and the IT team of the Input Pharmaceuticals who have given us provide this platform. Dharmendranath sir has left for some urgent work, so I would also like to thanks from him to everyone that all of you have participated and make this webinar highly useful. At present, we are having more than 3,500 of the viewership, which is good for the Zonal Meet. And thank you. Thanks to everyone from the scientific committee of the UPSOS. Dr. Tirupati Nath, you want to say anything?
Thanks a lot, everyone. And it was really nice to be here. And this initiative of doing these zonal meetings was really great. And we are looking forward for the other zonal meetings. Thank you.
Dr. Pankuri, you are the expert for today and you have seen all the speakers, and just from your side, few words. Ma'am, kindly unmute yourself.
Hello everybody, I am Dr. Pankuri from Gorakhpur and I have done my glaucoma fellowship from Arvind Eye Hospital, Madurai under Dr. Krishndas sir. So today presentations were really very nice and very elaborative, and I think everybody would have got advantage of listening all of these things. A few things which I want to highlight is the role of UBM, ultrasonic biomicroscopy in glaucoma. It is a very nice investigation and very fruitful investigation from the point of view of glaucoma, as it shows, it gives more information, more than even OCTs, because you can see in the scarred cornea where you cannot see through the cornea. It gives information about the anterior chamber and even the lens thicknesses and the status of lens and any foreign bodies or any tumors in the posterior chamber. All these the information can be collected through UBM. So I feel in primary angle closure glaucomas, we should give space to this investigation, that is very informative. And one more thing, all the this angle closure glaucoma which has occludable angles should undergo PI, laser iridotomy, because PI is not very destructive procedure, and I think it is more advantageous where the patients to you come from the remote areas and they are at the risk of developing angle closure. So it is, I think it is good if we can perform PI in occludable angles. And in lens-induced glaucomas also PI is good after performing UVM. Even sometimes, like if we measure the lens thicknesses on UVM and we can find out that if the lens are very thick, so it has a role to remove the lenses, clear lens extraction and put IOL where the patient will be benefited here. So anyway, everybody spoke very nicely. There's a lack of time. So I think more conferences will be like this, webinars will be conducted, and we will get.
Thank you. Thanks again to all the chairperson, moderator, and speakers from the office, from the side of the UPSOS, and hope to see you all again in a different platform of the UP. Thanks again. Thank you.
Thank you.